Morning once again. I wish to welcome you all to this morning's dissemination. And I pray that we all have a fruitful deliberation. To set the ball rolling, I'll invite a few of our dignitaries to occupy the front for me. Dr. Faustina Frimpong Engwa, please occupy the front row. Mr. Dominic Obna Achem, please come forward. Mr. Solomon Boama, Prof. Franchi, and then Mrs. Abna Akoto. Please. Thank you very much. With everything, we need God to direct us for us to be successful. So at this juncture, I'll call on Mrs. Abna Osayakoto to lead us with a word of prayer. Please come up. Thank you. Let's welcome her. Thank you.
Thank you very much. Shall we please be in a prayerful mood? Father, we thank you and bless you for an opportunity to come before thy throne of grace this morning. Thus far have you brought us. We started with GDHS fieldwork and all the other aspects of it. Now we are disseminating the data. We commit into your hands. We pray that we make full use of the data to enhance the work that we are doing, to bring progress into people's lives, and to also bring development in Mother Ghana. Thus we ask in Jesus' name. Amen.
Amen. Thank you so much. To welcome us for today's function, we have no other person than the Deputy Government Statistician, my own boss, Dr. Faustina Frimpong Engwa, to give us the welcome address for this morning's program. Please let's welcome her with a round of applause.
Good morning, ladies and gentlemen. Distinguished personalities here, the governing board and members of the Ghana Statistical Service, development partners, directors of Ministry of Health, directors of Ghana Health Services, directors or representatives of other MDAs, ministries, departments, and agencies, directors and staff of Ghana Statistical Service, researchers, colleagues from academia, esteemed members of the media, distinguished invited guests, ladies and gentlemen, good morning once again. It's a delight to welcome you all to today's function, where we launch the second phase of the Ghana Demographic and Health Survey results at the national level. This is part of a 2-month dissemination event aimed at making sure that the comprehensive data that has been compiled over 2022 and 2023, making it available for decision makers and planners to be able to help in our national development. Last week, we launched the key highlights of the Demographic and Health Survey, giving some highlights of what pertain in the country. But because of the nature of what the activity entails, we have decided to ensure that we unpack it in different phases to ensure that this information is made available to all. The Ghana 2022-2023 Demographic and Health Survey is a population-based survey designed to monitor and assess progress in the utilization and management of healthcare services. The goal is to furnish decision makers with critical information to facilitate well-informed decisions and policies within the Ghana Health Service and the health sector in general. The data was obtained from a nationally representative sample comprising 18,540 households across the 16 regions of the country. Our mandate as Ghana Statistical Service has shifted being producer-centered and to be a data user-centered in sharing our information to ensure that those who really need the information get it in the form they want it and how they will use it. Permit me to say that we, over the years, have ensured that we make information available to all our users in the format that they may use it. Distinguished ladies and gentlemen, may I digress a little bit and then mention to you some of the things that we have done over the years, making it sure that we provide information at that lower level. We don't only collect information from censuses and surveys, we also make use of traditional data. And one of it has been what we have won within the UN Datathon, that the Data Science Unit of Ghana Statistical Service, using our non-traditional sources of data, is able to win and won the World Prize for being the team that brought out the most innovative and winning 4 awards. I wish you give them a round of applause. Secondly, we also continue to use these sources of information to be able to provide activities. And therefore, using satellite data and big data, we're able to provide information on how ships dock on our land, and again, when they take off, and the kind of goods and trade vulnerability that we are able to change within the country. We are currently on the field conducting industrial census. This industrial census is called Integrated Business Establishment Survey. I am bringing this to your attention because this is also another form of a census whereby we will get information or an online version of all businesses within the country, whether big or small, for profit or non-profit, and again to be able to help plan and ensure that we are a fertile ground for other nations and other individuals that want to do business in Ghana. Today's function, ladies and gentlemen, is rather focused on disseminating as well as sharing information on the 2022-2023 Demographic and Health Survey. The survey was conducted with 17,933 households, and again, women aged 15 to 49 years were about 15,014 people that were interviewed. Within that same sample, half sample of 7,044 men aged 14 to 59 years were interviewed. We also gathered information about their nutrition. We also gathered information about children less than 5 years, and then again tested malaria using the malaria rapid diagnostics test and then microscopy. In this way, the survey covered a broad spectrum, including household interviews, assessment of women and men within specific age ranges, as well as health establishment and testing for children of different age groups. In today's presentation, ladies and gentlemen, we focus our attention on how we'll be able to use the Demographic and Health Survey to help estimate and also validate 44 indicators of the Sustainable Development Goals and indicators across crucial areas such as child health, nutrition for children and adults, maternal health care, malaria, infant and child mortality. One may ask, what is the essence and importance of these? We know that children or the health of any nation shows your economic resource or your wealth of resource. And therefore, if children who will be the future leaders are in good health, then they will be able to go to school, they will be able to survive, to live to adulthood, to be able to achieve their potentials. Most often than not, these children who are less than 5 years do not take care of themselves. Mothers or caregivers are their primary caretakers. And therefore, knowing the health and the nutritional status of these women goes a long way, since they will feed these children and nurture them. It is important to understand the nature of these adults as well. Malaria is seen as endemic in our part of the world, and therefore gathering information from time to time help us to monitor the progress we have made in terms of assessing the initiatives and policies we have implemented to see how far we have come in terms of reducing or eradicating malaria from our part of the world. And finally, we will also talk about infant and child mortality. And if the children you are giving birth to are dying before age 1 or between 1 and then 4 years, or that some of them dying before age 5 years, then the nation is at great risk. And therefore, when you have people surviving to these ages, then you begin to know that the nation is making headways in that regard. The statistics are disaggregated by region and locality type, that is urban, rural, and also for some demographic specific indicators, such as gender, age, education, and wealth status, or the household socioeconomic status, based on how we have measured it. We envisage that the insights derived from this report and the data that we will share will be released in shaping, implementing, and mentoring and evaluating policies and programs that have been undertaken throughout the years to be able to help Ghana develop. As I try to conclude, ladies and gentlemen, may I take the opportunity to extend our warmest regards and appreciation to all our partners, USAID, World Health Organization, the Global Fund, UNICEF, World Bank, COICA, UNFPA, UK Aid for assisting us, and Government of Ghana for assisting us to be able to provide the funds, and ICF for providing the technical support for us to be able to reach where we are. We also want to show our appreciation for our stakeholders, those diverse inputs and decisions that we took to be able to arrive the kind of elements that must go into the DHS survey. We want to thank you for your constant support and not relenting on our media, who have always supported us to be able to disseminate. We are in this business with you. Help us to be able, over the 2-month period, disseminate every segment and section of this huge, rich resources to ensure that the people that need it, the policy makers, the users, use it for the benefit of that nation. I hope that we all enjoy a fruitful deliberation. Thank you. Permit me, ladies and gentlemen, to make a little bit changes in our program. And so, after maybe the others have made their presentations, their statements, when we go into the presentation, we're suggesting that instead of just taking the presentation of maternal health, presentation on the children and adults, we will add presentation on child health. So we'll have 3 presentations before the evaluator comes to give the information, so that we can be able to save time and be able to work within time. Thank you for your attention.
Thank you so much. Let's do it better for her, please. Thank you. So now we know that for a healthy nation, we need to ensure that our children are also healthy, because they grow up to become healthy adults. At this juncture, we'll call on a rep from the WHO in the person of Mr. Dominic Kobna Atrim. He's a health information systems expert, to give us a statement on behalf of the funders of the DHS. Please, let's welcome him.
Good morning, everyone. Mr. Chair or Madam Chair, I'm not sure if we have a chairman for this occasion. The Deputy Government Statistician, Dr. Faustina Frimpong Ngwa, colleagues from the Ghana Health Service, Dr. Fufie, development partners, head of departments and agencies, head of institutions, the media, ladies and gentlemen. On behalf of the WHO Country Office, Professor Francis Kasulu, the GDHS 2022 funders, the World Health Organization is once again pleased to be here for the series of DHS 2022 results releases. We want to congratulate the Ghana Statistical Service once again for conducting this important survey and releasing the results in the most shortest time a country has done in the sub-region. This is the first time, once again, the DHS results has been released within a year, and we say congratulations to GSS. The GSS, through the support of key partners, the UK FCDO, WHO, the USAID, UNICEF, COICA, UNFPA, Global Funds, the World Bank, has implemented the 2022 GDHS, a very essential population-based survey, which will help us monitor progress on service utilization and management to inform decision makers. And today is an important day where we'll be looking at the MCH data and other disease-related data such as malaria. And we are very happy that these results will add to the large growing international database of population-based indicators, including the key measurable of the 44 Sustainable Development Goals. One key fact that we want to reiterate that in 2018, WHO conducted the score assessment, which indicated that we have only about 64% of SDG data, health-related SDG data available. But we can firmly assure that today, with the release of the GDHS results, and especially the MCH one that we are going to witness today, and other surveys such as the HHFA, the STEP survey, the IBES survey currently ongoing, we can confidently say that Ghana will definitely bridge the gap to more than 90% when it comes to data availability. And once again, we say congratulations. However, there is currently limited or no data platform on national, regional, district level accessibility on health services across the country. So if I want to sit here or be anywhere and I want to find out what Babato Health Center is offering or the type of service they are offering for the people within the community, I may have to call somebody from the district or call somebody at the Ghana Health Service. If we want to know how long do people travel within the communities around Babato Health Center, would we get that data? So one of the things that WHO, working with partners such as the UK FCDO and the USAID, is to see how we can now triangulate all the data that we have to provide better information on service utilization and access to care. WHO and UK FCDO will support work in this area this year, working with the Ghana Statistical Service and the Ghana Health Service to ensure we are able to integrate all the other data sources on a platform that will be accessible to all. So on behalf of Professor Kasolo and all the GDHS fund co-funders, we once again congratulate the GSS for this immense feat for producing these results within a year. And we hope that going forward, Ghana will use the data as an important source of information to the Ministry of Health to measure outcomes, especially when we are about to conduct the midterm review of the Ghana health sector, impact on our health programs, and also used to develop annual and sectoral plans. Congratulations, Ghana. Congratulations, Ghana Statistical Service. Thank you.
Thank you so much, Mr. Atriam. So for this first session, we're going to have 3 presentations. And the first presentation will be on maternal health care. And that will be done by Dr. Chris Opoku-Fofie, Deputy Director, Reproductive and Child Health, Ghana Health Service. Ladies and gentlemen, please let's welcome Dr. Fofie.
Good morning. Thank you very much all for your audience. It's really an opportunity to be here with you. And I will start by thanking the Ghana Statistical Service for the good work done, providing this vital information that will feed into the gap of health information that we so need to improve our programming. And I'll go straight to the topic. Here we'll be looking at maternal health. Maternal and newborn. Right. The outline of the presentation will be this. We'll be looking first at the background. We'll go quick to look at the methodology, highlights that will focus on findings, and then specific zoom on the key findings. And at the end, I should point it here. Okay. Right. Thank you. Right. So just a bit of a background on the methodology. The entire sample frame was the 2021 demographic and population and housing census that gives a whole frame. And then the first stage of it, as we see here, will provide the 618 clusters that were selected. So through that, then we have household that will be the tune of about 18,540 that were identified. The second stage, then we select out of that 30 households that were selected per each cluster to come out with the composite number that will be seen. So all women aged 15 and 49 within these selected households were now interviewed, and this is what will provide us the information that we'll be analyzing. And at this same point, we then pick anthropometry, that's measurements on anemia and also malaria that were measured to provide this information from the households. Then the fieldwork was conducted in terms of time frame from the 17th October 2022 to 14th January 2023. So now we're focusing on antenatal care, and let's look at the information that we derive from there. First, the trend in antenatal coverage. As we see here, we'll start with the women that receive antenatal care from skilled provider. That's at least one antenatal visit. And we see over the period from 1993 up to 2022, an increment from 85 to 98%, which shows that as we speak now, 98% of women in Ghana receive at least one antenatal visit. So that constitutes the antenatal coverage. Another important thing is the 4+, because when women are able to receive a minimum of 4 visits, then we assume that they will be able to receive the package of interventions that are required to be able to improve their health status and prevent complications from happening. And here we see how that has also increased over the years, up to 88% as we speak now. Though if that aligns a little bit or comes close to the global Every Newborn Action Plan target, which is 90%. So we're just very close to it, but we've not achieved that yet, and that shows us the gap that we need to work towards. Then we look at the ANC first trimester visit, the number of women or percentage that received their first antenatal visit in the first trimester. Here, this is very important because once you go early, then you'll be able to receive the package of interventions and also the knowledge that is required to be able to prevent complication from happening. And here we see how that increased from a paltry 33% up to 63% as we speak. This aligns closely with facility data that puts it somewhere close around 50%. So it means that we are very close. But here again, this is a huge gap that we need to cover so that a majority of women in Ghana attending antenatal service will be able to do that within the first trimester. So let's look at the number of visits. And here you could see clearly that we just have between 4 and 7 visits. There is a huge number there, but the global targets or expectation has moved towards the 8+. We're hoping to be able to get there, but our figures as we speak now from this survey is 39%, about just 40%. And from our facility data, that also comes something close, something around 50%. So it shows that, yes, we are there, and that is something that must be increased at all costs. Right. So we're looking at the timing of the ANC visits. And on the timing, we could see between the 4 and 6 months, we have up to about 32%. Less than the 3 months, that is where we have considerably a high number, that is 63%. So that simply reads that we have a good number of women attending their first antenatal visit within the first trimester, which is a positive sign here for us to consider. Now, within the package of care at antenatal, as we are familiar with, we're supposed to provide interventions that will enable women to be able to detect complications as early as possible and manage them. So we focus on key pointers, and during the survey, questions were asked to all women concerning these key interventions that can be seen as pointers. Number 1 is blood pressure. And we see that 98% of women had their blood pressure measured, and that is a very good measure because the second leading cause of mortality, maternal mortality in Ghana is what? Hypertensive disease in pregnancy. So if many of them are getting their BPs checked, there is a high possibility we'll be able to detect them. But the gap of 2% is something that we have to track and make sure every woman receives it. And not just once, but the number of times they visit. Urine sample 2, here 99%, and that is good. We have blood sample taken for other investigations, that is also good. Checking baby's heartbeat, because the essence of every pregnancy is to have a healthy baby, right? So if you go and the heartbeat is not checked, then we are not sure if there is a stillbirth or not. And here 99% answered that the heartbeat of their babies were checked, and that is good enough. When it comes to counseling services, here counseling about maternal diet, we have a bit lower, 94%, which means that we have to strengthen our effort in that direction. Counsel about breastfeeding. At the end of it, that is also nutrition for the newborn. We have the figure here is a bit lower, that is 89%. There's a gap there. We see declining level of breastfeeding in the country, and that is where the counseling starts. If we succeed with breastfeeding, we should be targeting the counseling for the pregnant women at antenatal. Then we asked about vaginal bleeding. The significance is to be able to detect knowledge on danger signs. And here we have 81%. So that's one of the major complications that can happen, that's bleeding. And if women do not know how it is, or we do not ask, then that is a bit problematic. We look at the tetanus toxoid vaccine, and here the first thing we hear is the number of women who have received 2 or more injections during the pregnancy. And that figure is 48%. However, when we widen the scope to look at those who have had total protection, has received protection against tetanus, that number is much higher, which means that the program is ongoing, though the number of women who might receive 2 but they had also received other vaccine previously, and therefore they are protected, and that is what the target is. However, if that target can be improved, that will be good as well. Right. So we're moving swiftly from antenatal to look at delivery service. At the end of it, all the effort during antenatal should culminate in a safe delivery. So let's see what we have at that point. And at the delivery service, the first one we see is the percentage of live births within the first 2 years. And here we are looking at delivery in health facility and delivery at home. The understanding is that when we deliver in health facilities, there's a likelihood that we'll be able to prevent complications from occurring and also manage them if they do occur. So across the years, starting from 1993, we see how the home deliveries and then even facility deliveries stagnated over a period up to 2003. I'm not very certain the circumstances that led to that stagnation. However, right from 2003, we see a complete mismatch there, or divorce between home delivery and facility delivery, where we managed to increase facility delivery gradually up to 86%. At the same time, where facility deliveries were increasing, we see a decline in home deliveries. And this has to do with TBA deliveries and all that happens. So it's logic to assume that our health system is getting much more robust and people are patronizing our services, and that's how we have many more. And at the same time, home deliveries and then TBA deliveries are being discouraged over the years, and I think that is a very positive sign to highlight. Cesarean sections by resident. Yes, over the years, we see how cesarean section rates have increased. We started somewhere within 5% of cesarean section in rural communities somewhere. But as we speak now, cesarean section rate nationwide is at 21%. But when we look deep to see where the cesarean sections are being performed, we see urban dwellers have about 27% as against rural dwellers of 15%. So as we speak now from our facility data, I can add that Greater Accra region, for instance, has a cesarean section rate of about 29% as at last year. But when you zoom into specific hospitals, some hospitals are doing up to 45% rate of cesarean section, which on its own is a bit alarming because we want to have more cesarean section, but there should be a way to make sure that those who need the cesarean section most are the ones getting it, not as a remedy for all other women who come around. So if you don't need it and you get it, you've deprived others from getting a life-saving intervention, and that is one direction we'll be looking in the near future. Assistance during delivery, and we say the percentage delivery of live births, as we see, where are they happening? First, we say 88% of births were delivered by skilled providers. So still here, we're doing well, but we are not there on the target yet. We expect to have all deliveries occurred or being managed by skilled attendants or still providers. So the gap there is something we need to work on. But when we look further on the other side, we want to see who is performing the delivery, which cadre of staff. And we see the nurse midwife group are performing the most of the cesarean section, covering almost 70%. We have the doctors about 19%, and then I want to look at the traditional birth attendants, which represent the home deliveries or what we consider to be unskilled delivery. That's about 7%. So putting all together, we are doing well, but we are not there yet. It's about focusing more our effort to cover the few 7% to join and also make sure all the deliveries are safe enough. We continue here to look at skilled delivery assistance by mother's education. It sounds to believe, we think that there is a relationship between the level of education of the mother and the type or venue of delivery, the type of delivery they opt for. And here we see that women with no education had only 74% of them had skilled delivery. Yet, When you look at those who had primary education, that number increases to 84. Secondary education, it increases to 92. And when you get to more than tertiary secondary education, that number increases to 99%. What does this simply mean? If we invest in education, definitely we'll be getting many more people attending or delivering within our facilities. So we have to focus a bit more in education there. We look at skill delivery by wealth. Again, there is a quick correlation between education and wealth, because once you're educated, you are likely to have a little bit more of resources than those who not, though it doesn't relate directly in all situations. But what we see is that those in the lowest quintile, wealth quintile, or those that are the poorest, among them we see 73% of them having skill delivery. And that increases in that same fashion up to 98% for the highest quintile, the wealthiest. So clearly, if you should ask me, education and wealth all will help increase skill delivery. However, it appears that education is increasing a little bit more than wealth on its own. So that is another observation that we have to take note in our programming. Looking a little bit into the country as a geographical space of Ghana, we say skill delivery is at 88%. Now let's focus on the specific regions. You could see here the deep colors, and I'm pointing at Savannah, Northern region, and Uti. These are areas we have lower figures around 72 and 70%. That's the lowest in Uti region. Whereas when we get to Greater Accra region, Ashanti region, these are the cosmopolitan areas, big with, we have 94%, and that is. So there's still some level of disparity which we have to work towards to be able to bridge that gap in terms of skill delivery. Now we move further to look at the next step, which is the postnatal care. After delivery, we want to be sure the woman will be safe, will be healthy to be able to go to the adory, and all of us will marry together. So let's see the interventions that happen at that level and what we got. Here, we first look at the postnatal care by place of delivery. And here we see when it comes to on the postnatal care for the woman and postnatal care for the newborn. Total for the women, we see 87% nationwide. But when we look at those that delivered in health facilities, 94% receive postnatal care or postpartum care. And that simply means that immediately after delivery, there are interventions to make sure they are safe. They are provided that care, as against 47% that deliver elsewhere. In this situation, they might not have access to postnatal care and have to travel to another facility. For the newborns, we see a similar pattern where 87% also nationwide receive that care, but we see 93% among those who were delivered in health facilities, and a slightly higher 52% among those who receive. It's not very clear why this pattern is like that, but then we have to look deeper to see how to strategize so that majority of women that receive care within health facilities will receive postnatal care as well. Good. So we look at the type of provider for postnatal check. And here for the woman, we see different levels here. Number one, we see in here care provided by a doctor, nurse, or midwife, a skilled provider. And we can see that is quite high, up to 83%. When it comes to care provided by traditional birth attendant, we see that declining. That is 4%, but that is significant. Remember from the previous slide, 7% of the deliveries were being attended by traditional birth attendants, and if 4% are receiving postnatal care, meaning that they are still competing with us strongly, the formal health sector. And we have 13% who have no postnatal check at all within the first 2 days. So here, this is a gap. This is an area we think that mortality for the newborn and even for mother increases within the first 48 hours. And therefore, if you have a whooping 13% not receiving any checks at all, the likelihood of complications that include death could be high within this group, and we will be working to cover this gap. Thank you for providing us this information. So let's look a little bit into the component of postnatal care for mother. What are the key pointer interventions that we want to have, and how much of it are we getting? So when women were asked, we checked on the blood pressure measurement, and we see only 74% of women are getting their blood pressure checked in the postnatal period. This is quite different from antenatal, where the figure was quite higher. So there's something happening. Postnatal check, it appears to have declined. About vaginal bleeding, discuss whether there was any vaginal bleeding. That number compared to antenatal has decreased further still, up to 65. Then also discussion on family planning. We see only half of our women have any discussion during the postnatal period, postnatal check on family planning, which is very important because family planning at that point will create the basis for mothers to be able to make their right decision and space their birth so that the children can thrive and develop well. So that affects mortality for newborn, their nutrition and all that. So there is a gap. When we look at those receiving all three checks, that is the combination of BP, blood checks, vaginal bleeding, and discuss family planning, that figure reduces further down to 45%. So this has implication for quality of care. The quality of the postnatal care that we provide should be able to guarantee that every woman receives the full package of intervention ascribed. And this is an area we have to work on as well. So we're looking at component of postnatal care for the newborn. And here, having identified the key intervention area, first we asked whether the cord was examined. Most complications, infection could start from the cord, and these are very avoidable areas. Only 78% had that done. Temperature measurement, again, if there is fever or hypothermia, that will be a very easy way to detect it through this. And here, only 76% are receiving this intervention. The mothers that were told to recognize if baby needs immediate medical attention. I mean, having them to understand when to call for help or go for assistance. 71% were. So it appears mothers weren't very prepared, according to this, to really care for the babies. And then last, we're looking at the weight, and finally, all 5 signal functions, the figure drops down to 60%. So the quality of the postnatal care for the newborn, we cannot be very happy about because only 60% are receiving the full package of intervention. Now we can then settle on other health issues. And on other health issues here, we're looking in straight to look at, We're looking at breast and cervical cancer examination by age. So women between the age of 15 and 49, when we check, we were examined to see issues to do with whether they were examined for breast cancer and cervical cancer. Looking at them totally, 18% had checks for breast cancer. And I think that correlates with figures that we have within our facilities, or any of you going to our facility. How often are you checked for breast cancer? That is low. And then checking for cervical cancer, that is even much lower, because checking for cervical cancer will be a bit more invasive, right? You have to undress, and most of the time we avoid those interventions. So among women within 15 and 29, so those much younger women, then we have between 14% having breast check and only 3% having cervical cancer check. When you take much older, between the 30 and 34, the breast checks are much higher. So So it appears that as the women get a bit older, they become a bit aware of examination of the breast and also for cervical cancer. And we see that up to the last age between 45 and 49, where breast examination is around 24% and only 9% for cervical screening. In general, we say these screenings are quite low and we should be doing a little bit more than that. Now, men's involvement in maternal health care. This is known to be an intervention that helps. When men participate in the care of women, the outcomes tend to be better. So here we look at women were asked the level of involvement, and this is what we see. That about 95% reported that their child's mother had any antenatal care during pregnancy. This is very important because a woman could be attending antenatal care, but if the husband or the partner is unaware, is not part of the decision, doesn't even know when he goes, it simply means that might not be even providing the resources that might be needed to care and supporting, and therefore that can also reduce him. About 52% were present at antenatal, and these are the lovely husbands that we want most of you here to be. Yes. So we're saying that these are the ones that accompany their partners to antenatal, and therefore they are likely to know what is happening and will be able to provide resources to support. And again, from the clinical perspective, when a man accompanies the partner, most of the health providers are intimidated and they usually try to sit up. And that's unfortunate, but that's the reality. So let's see how we all get involved so that we put things in perspective. Now, those that reported that their childbirth was in a health facility, so they knew where the delivery occurred and could mention it, these were 86%. Of course, when the delivery is happening, they are thinking about the adore and where they can then say they are the fathers. So they will always remember where the delivery occurred. I think the women should get up and fight a little bit and get the men involved, isn't it? Yes. Then we have 66% who went with their child's mother to the health facility during the delivery. Again, we have a couple of heroes coming in here, and I want all of you to join in there when it's your time to accompany your partners to do the delivery. Yes, so from here, we're looking again at problems in accessing healthcare. Let's look at some pointers that will show the challenges that usually women have in accessing healthcare. In getting permission, we know that in some sectors of our country, women will need some level of permission to be able to go because agency might be an issue. And here we see that still 10% of them are having challenges getting permission to go. These are all considered to be what? Harmful traditional practices that we should work towards addressing. Getting money for treatment, that number increases. Almost half, 45%, will have issues with getting resources, money for this. And therefore, we should strengthen our health insurance so that we can reduce financial barrier, but notwithstanding the role of husband, partners, and the family as whole, supporting to make sure that the family is robust and have resources for antenatal and delivery services is important. The distance to health facility, yes. Many women stay far away, and about 22% are reporting that they have issues to do with the distance, either too far or the roads are unmotorable and so forth. All that goes into it. And those that not wanting to go alone, I mean, people that will need some partnership or accompaniment and are not getting, and that becomes a hindrance. We're getting about 16%. So at least those that have at least one problem, we have as high as 54%, a little bit above half, always have one problem or the other. So if women are able to go through antenatal, deliver safely, we have to congratulate them because at every given time, there are challenges that are preventing them from accessing care. Now let's look at distance from healthcare facility. And here we're looking at distance, but looking at the travel times. Because in terms of distance, as you are familiar with, it might be easy to move from Kaswa to Winneba, despite the distance than Kaswa to Kolebu because of traffic, isn't it? So there are other perspectives that come into it, and here we see about 30% of our women have to travel between 30 and 59 minutes to be able to get into facility. The important thing to highlight here is that about 58% are able to access health facility in less than 30 minutes. And this is a global target. If you get a good number accessing in less than 30 minutes, there's a likelihood that in whatever emergency situation they find themselves, they will be able to get there alive and be supported to survive and thrive. So that is good. But still, we have some that are still struggling in about 2 hours and more. And that reminds me of women around Kwame Danso struggling to get to Mampong to be able to get delivery on a charcoal vehicle that can take about 6 hours and more. So these are all areas within our geographical space that we have to make sure that there's access to care in less time as possible. So now we're looking at the key results. These are just like summaries that you've seen already, just to mention them. As we speak now, we are happy to say that in Ghana, 98% of women aged 15 and 49 receive antenatal care from a skilled provider. That is good. We say 86% of births are delivered in a health facility, that geographical space where they have access to interventions to save their lives. We say 87% of women and 87% also of newborn had postnatal checks within the first 2 hours. The most critical moment where complications can ensue, this high number of people get that. But again, 87 is still on the low side. We can improve that. 18% of women have been examined by a healthcare provider for breast and also for cervical cancer. 5%. We're saying that this is completely unacceptable, it's low, and we have to increase that. 54% of women report at least one problem in accessing healthcare, and we're saying that we're looking at a time where no woman will have any challenge at all accessing healthcare. That's where we say we align with our universal health coverage agenda of leaving no one behind. So as we speak now, there's still work to be done in that direction. At this point, I want to say thank you.
Thank you so much. Dr. Fofie, you're doing the next presentation, so he's going to continue with the second presentation. Whilst he takes a water break, I think we're all impressed with how women's health in terms of childbirth has improved. And when our men accompany us to antenatal, how we feel good and the nurses treat us better. So our men, please encourage your brothers to do more. Thank you. So we'll go on to our next presentation, which has to do with nutrition for children and adults. And Dr. Fofie will continue. Thank you.
Yes, thank you very much. I'm doing this presentation on behalf of the nutrition program, precisely the Deputy Director, Nutrition, who this very moment is engaged in another assignment. So I'll be touching on the issues as we went through. First, it's the same background, and I think I won't go through that, right? So the outline is the same as the previous. We'll go through the same steps, and yes, the area to highlight here is we'll be looking at the nutrition status of children. We'll look at breastfeeding and infant and young child feeding practices. We'll focus on anemia, micronutrients, and nutrition status of women all together. Then we focus finally on the key findings. The rest is the same methodology. The methodology is the same structure that was outlined first, the framework, the household, the same numbers that we have. So I won't dwell much into that. Thank you. Then we're looking at now starting with nutritional status of children. What do we have on nutritional status of children? First, we're looking at percentage of children under 5 who are malnourished. It is our objective that children in our geographical space develop and thrive to reach their full potential. So if for any reason they are malnourished, that will attend against that. The first thing we see here is stunting. And when we talk about stunting, we're talking about children that are short for their age, isn't it? Yes, they are not achieving their full potential in terms of growth. That has implication for their cognitive development, which will also invariably affect our GDP, our economic growth, and all that. I mean, people who will get to a higher age and still not passing grade just because they didn't get the support that they need. What we see here is that from 33% in 1993, it has gone gradually down over the years up to 17% in 2022. So this is a positive sign. It's going down, but we want to decline the curve further. We need to go down into a single-digit stunting level. Now we have double-digit, isn't it? Just like the inflation. Now we see underweight. Also, those that are underweight here, we have 23% from 1993, and that has also been declining up to 12% in 2022. However, you can see there between 2014 and 2022, the decline has been very minimal. So, meaning that we might need to put in more effort to send the curve down. Wasting is just the sudden reduction in the body weight and all that. And we see here how wasting over the years has also declined, but it hasn't. Between 2014 and 2022, we see a sudden increase there from 5 to 6, which is significant. So when children are not getting all that they need, they lose weight, and that translates into wasting as we have. When it comes to overweight, we see how overweight is declining gradually, at least around 2008, where we were we had a bit more, but now with interventions and all other, it's going further down, and that is good for us. So let's look at the child growth measurement by sex. And when we look at that, we first look at females. We see stunting, 15% of females are stunted, as against 19% of males. We are not sure the reasons, but it appears that we are providing a little bit more food to the girls. That is good. The girl child. Let's promote the girl child more so that we have, because if they do not catch up at that age, it will affect us more. When we look at wasting, on the other hand, we have similar pattern here. 5% of wasting among females and 7% among males. When it comes to overweight, then we are bracket between males and females. So these are interesting things to check. Then measurement, again, by education. The percentage of children under 5 who are malnourished. We look at the level of education of their parents, and that gives an idea of the feeding practices that are taking place, the decisions that they make in terms of prioritizing which choices of food to be given to the children. Then we're seeing that those with no education, the level of stunting there is quite high, 24%, but that decreases up to a level of 6% for those with more than secondary education. So if you should ask me, the more we educate the mothers to first of all know the right food to give and all that, we might be able to prevent more stunting. So free school education and all that might impact in improving this for us in future years. When we look at wasting, it doesn't appear there is a direct correlation like that. Those without any education, 7%. We go to primary education, 9%. But those still with secondary and more than secondary still are hovering somewhere with 5 and 6%. That is obvious because when it comes to wasting, it has to do with having access to food within a period of time. So some shocks within the family circumstance can cause this problem and not lack of knowledge per se. Then in terms of overweight, we're seeing clearly in the streets of Accra is likely you'll be finding children that are overweight. That won't happen commonly in my village, for instance, which I refuse to disclose. So, so clearly, as you see, by the time those with secondary and more than secondary education, the women know it all. They have more plans and therefore decide on what to give to the children. And your guess is as good as mine. We most of the time think that if you can give your children chicken and this, then it means that you are giving them good food. And as a result, we'll get many more obese people within this group age. Now, let's look again at the wealth quintiles, starting from the lowest quintile to the highest. We are seeing that among those children that are stunting, we're seeing 23% among the poorest. So these are some of the issues that have to do with disparity and the social determinants of health that we should be focusing on within the community to make sure that education is available to all, not as a privilege. Because if we are able to provide enough wealth for everybody, definitely we'll be able to reduce stunting. Then we see at the end, only 8% among those with the highest wealth quintile are stunted. When we come to wasting, it's similar to the other where it doesn't come out clearly. We see different variation between those who are poor and those who are wealthy. They come very close. But when it comes to overweight, definitely those who are wealthiest tend to be more overweight. And we can see that happening here. Yes. So we're looking at where are the wasting distributed in Ghana. Ghana as a country, as we speak, we say 6% of our children are wasted. But where are they? So if you look at the map, you can identify your country, your village, right? And see the percentage there. So if you are from somewhere around Ashanti region, then we say the wasting there is 6%, far above the national average. Why is it like that? In a forest region where there are lots of food, there are everything. So it means there are other factors that we need to consider so that we can be able to deal with the issue of stunting. On the other hand, areas around savannah where probably economic situations are not that much, wasting hasn't been slightly below the national average, that's 4%. So yes, this gives us a good context to be able to see where we are putting our intervention so that we can support and get all children to be okay and not leave anyone behind. Good. Now we're looking at overweight again. On overweight is 2% for the whole country. And where are the overweight? I was looking at Accra to see high level of overweight there, but it doesn't appear that is the case. I don't know why Bono is having as high as 4% of overweight. Is there a particular food they are eating there? Maybe we'll be asking further questions to see why we have more overweight children in the Bono region and appear similar thing in the Ahafo region. Whereas when you come to Accra and even Ashanti region, it doesn't appear to be like that. Maybe I'll be finding out. Maybe the fufu in the morning who will be contributing. I'm not really very sure. Thank you. Yes, so we are looking here again on the child growth monitoring. So for the monitoring, we're looking at a percentage of children under 5 who had selected measurements conducted. If you're able to monitor them, you know where things are going wrong and put in the necessary intervention. But if you do not measure, you do not check, then those type of vital interventions could be missed. Number one is weight. If you're able to check the weight, then we are seeing that only 50%, so half. So half of them is charge-free. Nobody checks, and therefore you don't know whether the child is underweight or that sort of thing. You are unable to say she received more food. When we talk about that, we check the height, then you'll be able to know who is getting stunted, isn't it? It's not achieving the targeted height, and therefore we put in intervention and decide that probably they should focus on giving specific food to. But if you don't check, we won't know. We check the mid-upper arm. circumference. That's another way of checking how much of it in terms of their diameter, and we see 22% have gotten that checked. Then to have the combination of their weight and height, only 38%. Then the three of them together, 21%. This has serious implications for programming. We have to look at what are the contributory factors, what are the reasons behind it. Is it lack of equipment? Is it lack of skill? Why is it that we are unable to? Is it that the board, measuring boards are too heavy and difficult to carry them along? We have to do the in-depth analysis and see what support will be needed so that at the end, majority of children in Ghana can have all three interventions, from 21% targeting somewhere above 80%. That should be where we should be looking at. So we're looking at stunting children under 5. Again, when we look at this group, over the years, we see a decline, right? Let's look a little bit into detail. From 1993, we see that we started from 32% and we've gone down, and as we speak now, 17%. That is good, but if you look at the charts, you see clearly that the declines are not galloping. They are not going in wide ranges, and we have to see what to do in terms of intervention to get major decline in terms of this. Between 2008 and 2014, the decline was significant. We didn't see the same thing happening in the last one. Then we go further to look at the geographical space, the distribution, and you see that somewhere around Ashanti that we have the same 17%, but when you look at other regions up, you can see some having rates that are by far above the 17%. So we might need to put in focus in such areas to see how that can be changed. Stunting by maternal education. Again, we're still looking at how maternal education and wealth quintile influence stunting. And here we see that women with no education whatsoever have by far higher percentage of stunting. That is the 24%, and that decreases up to 5.75%. That's those who have secondary education. But when it comes to wealth, it's a similar pattern that starts from 23% and also decline up to 7%. So clearly it supports the previous notion, ideas that we've identified, that when we invest in education and also in wealth creation, we might be able to work a little bit to reduce stunting at different levels. So the wasting, looking at wasting children under 5, we see the decline here again from 13% up to 6% where we are. This offers us an opportunity to see the differences between all the surveys that have been done. And then we go further to look at the country where we stand. So keep looking at where you come from and see what is happening there and what kind of support that we need to give so that every region will be below that average that can be sent further down. But clearly, Ashanti 7.7 is coming up clearly that there are issues there within Ashanti that needs to be addressed. So I've mentioned Ashanti, and it means most of our interventions should be focusing in that area, supposedly. Underweight, we see the same pattern, and we're seeing that there has been a decline. We are happy with it, but it's good to highlight that over the last year, we didn't have a decline as we expected. There has been a sudden increase there, and it's good to understand what are the circumstances around it. Why is it that from 11, we didn't go to 9, and we went to 12? So we have to look at that. And in terms of regional distribution, you can see the figures there, and I'm looking closely, seeing 11% somewhere. I'm seeing 12%, yes, and some are still higher. So we have to. It appears that this is quite uniform, apart from some that are doing much better, like 7%, that is compared to other regions. Yes, anemia is another very important point, because when children have anemia or even mothers have anemia, it has implications in terms of mortality and also for their ability to fight infections and thrive. So looking at anemia over the years, we see 2003, 76% had anemia, and the different strata that we can align. But when it gets to the year 2022, from this survey, we see a decline that has gone down up to 49%, and then we are seeing differences in terms of the percentage that have severe anemia, those that have what will be seen as moderate anemia depending on the values, and those that have mild anemia. These are different percentages. So it appears that as of 2022, we have about 27% that have mild anemia, a little bit more having the moderate anemia, and much smaller having the severe anemia, less than 1%. But it will be good to work towards having, if anything at all, mild anemia dominating the whole and nobody with moderate anemia. So this is something we can work on as well. It's a gap we can do something about. Okay. So we're looking at, anemia among children between 6 and 59 months. And here is across all regions. So I won't go through all of it, but just look at your region and see what is happening. So I'll focus on the Ahafo region that has the lowest rate, as we see here, 35%. And among that, the percentage that is mild anemia is still high, 25, with only 9% with moderate, right? But when you go to the last one, northern region, we're getting a high percentage of anemia, and the distribution is quite different. Here we are seeing a higher percentage of moderate anemia compared to the mild anemia, which means that the problem is not just once. This is something that will require deep attention, prolonged effort to be able to address. If not addressed, these children could have, there could be issues there. So for me, there is a red flag in northern region, upper east, northeast, all these regions within the north, including Uti. And I think you understand why we have a lot of intervention in that area. USAID and partners, red flag. We have to still continue to do more in that area. Yes, so with this, we come to the end of nutrition status. We look at breastfeeding. Let's see how quick we can go from here. And also infant and young child feeding. The first one is early breastfeeding. And we're saying that 97% reported that they ever breastfed. And that is good. However, we expected this to be 100% because ever being at least once. Every child in this country at least should have had some breastfeeding, or every mother should have had that. So when we put, in terms of early initiation, that is the number of women or women who put their baby to breastfeed within the first hour. This is very important because when they do that, then there is a likelihood that they can sustain breastfeeding, and that will also inure to the benefit of the baby in terms of sending colostrum and all that. We've seen that only 58% are doing that within the first hour. That is not good enough. We need to work on that. Exclusively breastfed for the first 2 days. For us to sustain breastfeeding, we look at the first 2 days to see whether you have initiated and sustained it for the first 2 days whilst in the hospital. And that's a good marker. If you do that well, it's likely you might be able to continue at home. But if you do not do that, then what's the guarantee that when you are on your own, even at home, you do that? So that 81%, we know that number will drop, but we need to work on that as well. Breastfeeding status of children under 6 months. First, we're looking at breast milk only. Those who do breast milk only, unfortunately, we are not getting 90% and so. We are getting 53%, and that is alarming. We are doing other things. Those who never breastfed, that's no breastfed, that's 3%. Now let's look at different combination. Breast milk and formula and or animal milk. That one also here increases to 9%. Breast milk and solid, semi-solid or soft food, that's a little bit higher, 11%. And then breast milk and plain water only, that also increases. So it means despite all the information we're giving that the breast milk contains the water, everything for the baby, a number of women are still giving water in addition to the breast milk. So we want to focus on this, that should give breast milk only, and that might help. And now breast milk with non-breast milk liquid, that's less than 1%. Good. Introduction of complementary feeding, that's when they need other feeds. As we speak, we say at least 7 out of every 10 have complementary feeding. And that is fine. And that constitutes, they've had solid, semi-solid, and other soft food the previous day to the survey. And that is a good sign. We're looking at minimum acceptable diet by residents. So we're looking at those who have the minimum acceptable diet, all is 23% for the country. Then let's delve a little bit to see where they are coming from. Is it an issue of where they dwell? For urban dwellers, that is 26%, and rural dwellers, 21%. So it doesn't appear to have much influence there, but though there is a preponderance towards the urban, and we'll have to look deep into that. Unhealthy eating practices. What is it that people are eating? We asked, and answers that we got is that 32% gave sweet beverages. So, I mean, once gone are those days, you're able to give Coca-Cola, Fanta, meaning that you are wealthy. Today, the trend has changed. We're saying that these are not the healthy things to give, but still we have about 32% that are doing that. Other unhealthy food here, we're talking about chocolate, the processed foods and all that. We're still getting about 33%. And only those that have zero vegetable or fruit, that they give anything but fruits, and they do not consider vegetables and fruit, we are having as high as 31%. So we're saying that Ghana is an agrarian country. We have a lot of vegetables. The vegetables are good for our children, and therefore we want this 31% to vanish. It should get to zero, and we should put in intervention to get that to happen. Now, infant and young child feeding. We have specific indicators there, and we are focusing on first looking at those that were fed from a bottle with a nipple. Already we started intervention showing that the bottle with a nipple shouldn't be. However, we see 21% saying that yes, that's what they are doing still. They fed egg or fresh food. That is positive. We are seeing 62, but this is something we expected to see by far more, probably in the 90s, so that at the end the intervention can work. Giving at least 2 milk feed, we're getting 26%. This is an area we could spread a bit more. We have fed solid, semi-solid, soft food, but also including milk feeds and all that. We get that about 49%. Then those who fed foods and beverages from at least 5 to 8 of the food groups. Once you are getting varied group and selecting from them, you are doing something good. That number decreases further. Then fed breast milk, we have 67%. So yes, this is providing us important information that when we go in depth to look at it, we might be able to provide a little bit more interventions in a different fashion. So looking at among women within that same age group, that spoke to the healthcare providers. We look at those who were fed, right? And here we're saying that 50% of them for the entire country, right? Those who had counseling, appropriate counseling that we know will translate to change, behavioral change that we know to the benefit of the children. Only 50% had that. And this 50%, we see 53% in the urban area and then 46%. So in general, I think this is low enough, and we can work towards improving the counseling, because that's how we can get women to change their behavior and take practices that are helpful to women. So now we can focus on anemia, and under anemia, there are specific things here to highlight. We're saying that 49%, almost 50%, half of children have any form of anemia that is defined as less than 11, HB less than 11 grams per deciliter. Then we go further to look at the level of anemia. We have mild anemia, 28%, moderate anemia, 20%, and severe anemia, less than 1. So this is a reflection of the previous tables that we showed. But the major highlight is that almost half, and we have to keep eye on that. Yes, so trend in anemia over the period between women, among women and children. Let's see what has happened. From 2003, where we had something like, for children, 76%, this has declined further over the years up to the current 49 that we have. But again, it's still unacceptable. It appears when it comes to the mothers or women, we see for the same period of time from 45% declining gradually up to 41%. This gives a slight impression that because the women control the food, they prioritize themselves over their children. If I'm wrong, maybe women do it differently so that we'll have more anemia among mothers than children. So let's look at it. Anemia in women. Then we look at it, and we see in here closely where among pregnant and non-pregnant women. And this is very interesting. I want you to look at how first, yes, we're getting 51% of pregnant women in Ghana, as we say, have some form of anemia. But how different is that from women who are not pregnant? That is also 40%, which stand to show that the interventions that we are putting in to prevent anemia during pregnancy is not making a lot of difference. The way forward probably might be to tackle women who are not pregnant, get them with preconceptional care so that they are prepared, reduce anemia before they get pregnant. Then this might go further. So these are very useful considerations we'll be looking at. We're looking at mild anemia. Again, we're seeing 29% for pregnant women, 22%. So there is a gentle gap here. Moderate anemia, 23% and 17%. Severe anemia, less than 1%. So for me, the focus is to look at any form of anemia and make sure that those women that are not pregnant, just from their routine menses and all that, we support them to be able to get out of anemia before they get pregnant, and then support them during pregnancy with intervention. Then we can drop this rate. Their babies will do better, and everybody will be happy. So now micronutrients. Under micronutrient, the first thing that we're focusing on is percentage of children between ages 6 and 59 months that receive iron-containing supplement. We've seen that only 51% had that within the month. But when it comes to vitamin A, the period notes here is 6 months. Within the last 6 months, that is much higher. So it appears that we are prioritizing, or we are focusing on vitamin A and getting a bit more of them doing that. However, the data is telling us that we should be looking more into the iron for children because there are so many of them that need that. In terms of deworming, just 46% of them had that within the last 6 months. And again, that is an issue that can be increased or can improve. Then on iodized salt in household, here we're saying that 91% of households had their salt tested. And of that, 80% of the salt tested contain iodine. So this is a good sign. We are working in a good direction, but these figures can be improved. This 80%, we can move towards universal level where every salt in the country is iodized, right? So finally, we're touching on nutritional status of women. And here, we're looking first at women within the ages of 20-29, categorizing them to those that are thin, normal, overweight, and obese. What we see immediately is that within women within that age group mentioned, we have only 5% that are thin, 45% are normal, right? We have 28 overweight, and then the obese 22%. But how does that play within the next age group where we're talking mainly of adolescents, women within the ages of 15 and 19? Here, what we see here is that we have 16% that are thin. This has great implication because this age group, we know they have issues with their eating habit, other issues, anorexia nervosa, their appearance and all that. So we should have intervention for them so that we prevent them from having high. But much important here is to have 70% that are within the normal range. So if we have most of adolescents within the normal range, then it means our interventions have to be focused within this group. They continue the good habits here and develop them over time so that when they become adults, they don't suddenly bloat and fall within overweight and obesity. So this is a highlight for our next intervention target group. Yes, so the minimum dietary diversity among women by residence. Then we are saying that those who consume foods from 5 or more of the 10 food groups, what we realize is that half of them across the country, that's 50%, did that. Yet, when you go in depth to look at it, 52 were from the urban setting, whereas 47 from the rural. So here it doesn't look like where they dwell makes a lot difference. We don't see major disparity there, but there are differences that we need to consider in our programming. Unhealthy food and beverage consumption among women by residents. Again, we saw that across the country, those who take more of the sweet beverages, that is 37%. But where are they from? We assume that they are from urban areas. Let's see whether that's true. The study is telling us that 45% are from urban dwelling, whereas 27% from rural dwelling. When it gets to unhealthy food, the entire country, or for Ghana, is 28%, but we see more in the urban and 21% in the rural. So what I want to highlight here is that we know this is a problem within the urban communities, yet the rurals are not left behind. So we cannot leave the rural communities out of this conversation. We have to focus in that areas, but put more emphasis in the urban areas because that is where the problem is more. Without putting any intervention there within a short time, it's likely the rural communities will have the problem as much as the urban. So it's about making decisions where we put our interventions and where we put the focus. At this point, the results that we are happy to go home with, we're talking about 17% of children under the age of 5 are stunted. We are unhappy about it, and we have to work towards reducing that. 6% of children under the age of 5 are wasted, completely unacceptable. There's nothing to waste in this hard economy. We have to make sure that these children are rescued and put back on track. 12% of children under the age of 5 are underweight. Again, we're saying that it shouldn't happen. We have to make sure this number is reduced. 53% of children under the age of 6 months are exclusively breastfed. I've landed. Yes, and we're saying that figure is low. We have to make sure, remember to tell your neighbor, to tell the friend, to tell the husband, to tell everybody's business. Exclusive breastfeeding, so that everybody does that. 99%. 49% of children aged 6 to 59 months. 51% of pregnant women. 40% of non-pregnant women have anemia. This is completely unacceptable. Why so much anemia? Among those who are not pregnant, those who are pregnant, children, everybody has anemia. So probably we should go and mine more iron and distribute freely. Everybody have to chew iron so that we can solve this problem. But on a serious note, this has to be dealt with. 50% of women aged 20 to 49 and 14% of women within that same age group are overweight and obese. So as we are struggling with children having stunting and all that, the women, we are saying, are investing a lot into excess fat, which we can deal with. It doesn't sound nice, isn't it? So let's see, what do we do so that the overweight and obesity among women can be handled so that we don't get to epidemic proportions. 80% of household salt tested contain iodine, and that is good, and we are saying we can improve that. I think that is it for now, and thank you very much.
Let's do it better for him. Let's do it better. We've had interesting facts from the report, and we know that our health is not in the best of conditions. We need to do a lot more. We need to find out where to mine iron so that we can all start chewing some and cure our anemia. Next presentation will be by Dr. Emmanuel Boateng, Principal Statistician from the Ghana Statistical Service, and it will be on child health. Dr. Boateng.
Okay. Thank you, Madam MC, and thank you, Dr. Fofie. We assume that the mother has given birth, the children has been given food, and the aspect we are looking at is their health conditions and common illness and how mothers handle them in case their children are not well. So, way of highlight, I'll look at services, child illness and feeding practices, and then key message. So I'll start by giving this definition: vaccinations. Children within 12 to 23 months or 1 year to 2 years should have or should be considered as fully vaccinated if they have taken BCG, 3 doses of DPT, 3 doses of polio, excluding polio at birth, and 1 dose of measles or rubella. And they are also the same group as 12 to 23 months are considered as fully vaccinated if they've gone through all this list up to measles, rubella. So it means the basic antigens is a subset of the national schedule. So the national schedule have a lot of vaccinations or vaccines that the child have to take. But we consider this ones as basic that each child should have. So we could see that the target is, for Ghana is 95%, but the DHS 2022 recorded 75%. And you could see that the year 2008, we recorded 79, we dropped to 77, 2014, and further dropped to 75 in the year 2022 DHS. And then 2% of those children have never received any vaccination. So the 2%, we try to look at the 16 administrative regions, and we have the highest in Northern region, recording 9%, and the lowest in Bono, in that order. Vaccinations by sex of children within 1 year to 2 years or 12 months to 23 months. So 3 doses of DPT containing vaccine. We had 88% of women or children or girls receiving that compared to 90% of male children or boys. The last dose of pneumococcal vaccine, we recorded 86% for female and 90% for male. The children aged 24 to 35 months, we recorded 70% of female receiving this and 75% for boys. So you could see that in each case, the male children receive more than the female. So what is driving this? We are saying that the higher the education level of the mother of the child, it's more likely that the children will be vaccinated. If you look at women with more than secondary education, we have 82% of their children being immunized compared to just 42% of women with no education. In the same way, the worthiest quintile of women, we recorded 73% of the women in worthiest quintiles sending their children to vaccination compared to 42% in the poorest or the lowest quintile. Vaccination coverage by region according to or by national schedule. That's the full list. Ghana, we had 56%. We were able to record 56%. And we have disparity in the regions with Greater Accra recording 72% and Ahafo, Northeast, hovering, and even Savannah and Northern region hovering around 31% and 42% respectively. So child illness. So basic illness that we identify during the survey period or 2 weeks preceding the survey were acute respiratory infection, fever, diarrhea. So we recorded 2% of children suffering from acute respiratory infection, then 50% of fever and 13% of diarrhea. And you could see that 54% of the 2%, they seek advice for treatment. And then 57% of the 15% also sought advice for treatment. And then 51% of the 30% also sought advice for diarrhea. In each case, in all the cases, we could see that the survey reveals that mothers seek a lot of advice or treatment from public sector compared to the private medical person or NGO or any other private sector. Then feeding practices during diarrhea. Mothers were asked when their children were having diarrhea, how were they treated the last 2 weeks before the survey. And we divided them into food and then liquids. Food and liquids. So we expect that when the child is not feeling well or passing through, you should be giving more food or liquids so that to replenish what the child is or has lost. So 6% according to the food, The 6% said they were giving more food. 32% said the same food that they have been giving to the children, that's where they were giving when they were experiencing the diarrhea. And 53% were giving less of the food. So it means that's where the emphasis is, that they need to be giving more to replenish them. But more than half were giving, were giving less. Then when we come to the liquids, 20% were giving liquid as more, and then 38% were giving same, and then 37% were giving less. So in this case, the giving less is permeating. So we need intervention or advice to parents or mothers to be able to give their children more when they are not feeling well. So percentage of children under 5 with diarrhea in the 2 weeks before the survey, 51% said they sought advice or treatment. 40% were giving food from ORS packets. Then 57% were giving oral hydration therapy, which we don't know. I think the recommended one is the food from ORS packets or zinc and ORS. But as high as 57% giving oral hydration therapy. And 36% were giving ORT and continual feeding. And the 50% were also giving homemade fruit, which we don't know how it looks like. So these are the key takeaways. 75% of children aged 12 to 53 months are fully vaccinated in basic antigens. The 56% of children within 12 to 23 months are fully vaccinated according to the national schedule. And among children under 5 with symptoms, treatment or advice was sought on the following: 54% with symptoms of acute respiratory infection, with 57% with fever, and a little over half with diarrhea. 36% of children with diarrhea receive oral rehydration therapy and continual feeding. Thank you.
Thank you, Dr. Boateng. So we've had a lot of information, and now we're going to get remarks on what we've listened to so far. So the first remarks will come from the health sector, and that will be by Mr. Solomon Boama, MAE Specialist, Ghana Health Service. Mr. Boama, please.
Thank you very much. Yes, so regards from the Director General, Dr. Patrick Kumar-Boaje, and the directors at the Policy Planning, Monitoring, Evaluation Division of the Ghana Health Service. And thank you, presenters, for the informative and insightful presentations that have actually highlighted our performance as a service, the basic remarks that we as a service can give, sitting down, looking at the presentations, is that these population-based findings actually are in resemblance with our routine health data. And our basic remark is that it resonates well with us, and then we want to appreciate the efforts that have been put in by the Ghana Statistical Service to present this to us. Well, as an M&E specialist, sitting down looking at the presentations, I want to appreciate the data analysis that you have shared from the 2022 Demographic Health Survey, which actually shows the progress and challenges of improving maternal, child health and nutrition services with the Ghana Health Service. And we, as a service, are particularly interested in these findings, especially the factors that are associated with the findings that we have just witnessed in the area of the skilled antenatal care, skilled delivery, birth attendance, postnatal care within the first 24 hours, and also the child health and nutrition services that we have just listened to the presentations. These are key components of WHO recommended maternal health care utilization, which is very essential for reducing maternal mortality and mortality. We, as a service, would want to commend the efforts of the Ministry of Health, Ghana Health Service, and our developing partners for the effort to actually ensure increase and equitable access to quality maternal and child health services. We also recognize the gaps and challenges that remain, and we all saw it evidently clear from the presentations. I would not want to paraphrase what was actually shown in the findings, but we also admit that some of these challenges are influenced by some factors, such as the low coverage of national insurance, the socioeconomics, and geographical disparities, the cultural and religious barriers, and the quality of care issues that affect the maternal child utilization outcomes. And we use this opportunity to urge all stakeholders to work together to address these challenges and ensure that our women and children are not left behind in accessing a life-saving maternal and child health services they need and deserve. For this particular session of dissemination, we hope that this presentation, the highlights of this presentation from the 2022 Ghana Demographic and Health Survey will stimulate further discussions and collaborations among partners and the experts in the field, so that our efforts in achieving the universal health coverage will be on track and then will be achieved as envisaged by all partners. Thank you very much.
Thank you, Mr. Boama. From academia, would invite Prof. Steve Crunchy to give us remarks. Prof. Kwache.
Thank you very much. I have a very bad cold. That's why I don't want to infect anybody. My name is not Kwachi. My name is Kwanchi. S.O. Kwanchi. That is my name. Realized on time and published, disseminated are very, very important for us. But let me pick on a few things that I need to highlight from the presentations that have been made. Thank you very much, Drs. Fofie and Boateng, for the presentations. On maternal health, we can see, and we all saw that antenatal care is almost 100%, almost universal in Ghana. About 98%. But when we look at health facility delivery, that is 86%. Now the question I asked, what is happening at the ANC service delivery points? That people go for ANC services, but some 12% of them decide not to deliver at those facilities. Maybe we need to interrogate it. And for me, that is important for us, because the expectation is that once you go for ANC, then you are giving a lecture on how important it is for you to deliver at the health facility level. So if some choose not to deliver there, then I think that we need to find out why. Otherwise, we'll be happy that everybody is going for ANC services at the facility level, but when it comes to delivery, people shy away from the health facilities. So what is happening between ANC and delivery at the health facility level? I think this is an area that perhaps somebody can choose for his master's thesis. Are there any sociocultural practices that prevent people from delivering at the hospital? Of course, having 86% of them delivering there shows an increase over the years. But I was expecting that the 98% that went for the ANC services at the same facility will go back there to deliver. So we need to explore and find out. One other thing that I want to comment on is ANC visits in the first trimester, which from the report increased from 33% in 1993 to 63% in 2022. You see, this is about double what we had in 1993. And we can all say that that is good. But between 1993 and 2022, that is about 29 years that we took to about double it. And we are still at 63%. So maybe we need to do more in this area and then ensure that, as Dr. Fofie even presented, we need to have the visits 8 times or more. And that is just around 39%. So we need to do more in these areas as well. There were some of the services that were provided, like BP testing and other tests that were also given. And the questions, some were very high at the ANC level. When it comes to the PNC, I'm not talking about the party, but postnatal care, it drops. And the question I asked myself was that, how do we have it so high at the ANC level? Is it because at that stage we think that life is threatening and therefore we must ensure that we take steps? Because somewhere in the 99%. But when it came to postnatal care, some dropped. And I think that we need to marry the two to ensure that if it is, for example, taking care of the BP, which was as high as 98% at the ANC level, when it comes to PNC, we must also try and get to the same level. And these are about professionalism in terms of those who are delivering those services. And I think that we need to do more, because when you look at the content of postnatal care, those receiving blood pressure measurement was 74%. But for ANC, it was almost 100%. So the question I asked myself was, why the differences? In many of the indicators that were also presented, we find that it varies across the regions. So at the national level, we may be doing well. It is increasing. But when we look at within the regions, then you realize that we are all not the same. Of course, we cannot all be at the same level, but that should guide us in trying to inform our policy with what we see, so that we place emphasis where it has to be. Again, you see that education is very important. In all the indicators, when it comes to delivery at the facility level, ANC, and all the maternal health indicators, you can see that education plays a big role. And that is why I think that any effort at improving education, we should be able to build a consensus around them and then move the process so that everyone receives education, especially the women, because they carry their pregnancies, and at times, if you know that life is becoming threatening in terms of the pregnancy you are carrying, you need to take a decision. There was one of the reasons that were given, indicating that permission to go for health care, 10% of them said that that was a reason. I mean, when you are sick, why should you ask for permission to go to hospital? One area was money. Maybe some of the women, especially those with little or no education, were not working and they are not earning much money, and therefore they need to depend on others. So to be able to reduce this dependency syndrome, education is critical. And once you get education, the possibility of you to work and earn income and control the income yourself is also high. And we saw it in some of the indicators where the wealth quintile, the better it was, the better the results that you get. And so when you relate education and wealth creation, the two are bedfellows. And everything that we need to do to get it to better level, I think we should do so. There was the issue of male involvement, and that was of interest to me. Several years ago, we've been talking about male involvement in family planning, for example. And here we are talking about male involvement in maternal health, in terms of men going to the health facility with their spouses, either for ANC care or PNC, or even common illness, going with the spouse. I think that we may not be able to fault all men. At least we can see that gradually we are doing better. But what we need to ask ourselves is the attitude of some health personnel who, when they see a man following a woman to the ANC, they will ask you whether you are also pregnant. Because that place is for pregnant people. And you are not pregnant, why are you there? So I think that we need to also look at the professionalism that is displayed at the ANC and PNC service centers, so that you can get more and more men to accompany their wives or spouses or partners to these places for services. I'm also drawing attention to the regional disparities and not limited only at the regional level. Of course, DHS, the type of data that you produce the processes that you go through, at the district level, the sample size will be too small to be able to do rigorous or robust analysis to bring out those intra-regional disparities. But of course, we shouldn't lose sight of what pertains within different regions. So in one region, the result may be good. But before you are aware, when you go there, you realize that it is just about 2 or 3 districts that are bringing the good results to that level. And when you go to the west regions, you can also identify which of the districts are creating the troubles. So even though we have these at the national level, we should try and see how we can delve deeper. And thankfully, the census also provide us some avenue to look within some of these areas to see how we can judge at the district level as to what is happening therein. Okay, so let me leave maternal health and go to nutrition and children, nutrition for children and adults. There are a few things that I want to highlight in this area. When it comes to stunting, we realize that, or as Dr. Fufi presented, 70% of children under age 5 are stunted. They say too short for their age. Maybe when I was younger, I would have been a candidate within the 17%. But is it always the case that it is because we are not fed well, or it is genetic propelled? My father was short. And so maybe I took it from my father, not that I didn't have food to eat. So some of these investigations, we need to also explore and find out whether it is just because food is not available or there are genetic reasonings behind it. When you compare it also, we see variation between males and females. And when it comes to stunting, we see that it is lower among females. But when it comes to overweight, then the women take over. So, Dr. Fufi was talking about the women controlling the kitchen. Is that the case? That because women are in the kitchen, they eat the best of the meals, and they eat in larger quantities than normal, and therefore it brings about overweight? Maybe we need to look at it. Or is it as a result of lack of exercise? If we are able to also look at exercise cross-tabulated with overweight and stunting, perhaps we'll be able to understand some of these things better. Because there are some women who don't want to do any exercise. When you move along the streets early in the morning, you see more men running and jogging and walking. These days we see women also coming in, but when you look at the two, you can see more exercise among the males than females. So perhaps that angle too will have to be looked at, so that it is not just looking at stunting and overweight on their face values, but what goes into making women become better or worse compared to men. You know, we have been talking about breastfeeding, exclusive breastfeeding, for a long time in this country. When it started, I had not even started making babies. But we still haven't been able to reach where we should be. And so if you have 53% of children under 6 months being exclusively breastfed, with 47% not done the same way, then there is a gap. And I don't think it is only the work of the Ghana Health Service, but the Ministry of Education, the NCCE, and all of us to join. There were some kind of myths surrounding breastfeeding, which I heard. Some arguing that when you breastfeed a child exclusively for 6 months, when you are stopping him or her from exclusive breastfeeding, after that and giving supplementary food, the child will refuse it. And that creates problem for some of the indicators that we are getting here, stunting. They become stunted. I don't know how scientifically true it is. I doubt if that is the case. But you see, when there is perception, at times perceptions are stronger than the reality. And so when these perceptions are there, we need to try to address them to ensure that everyone gets the child exclusively breastfed for the first 6 months of their lives. 47% are not there. And so there's work for all of us to do. On complementary feeding, the report, I think, mentioned that we have 41% of children 6 to 23 months receiving the minimum number of food groups during the day or night. I think that was not presented here, but I picked it from the main report. So if it is just 41%, then we have 59% who did not. And this must be a source of worry to everybody. When it comes to sweet beverages, you know, the report says that 32% of children 6 to 23 months, were given sweet beverages. 33% were given unhealthy foods, and 31% were not given vegetables or fruits. Now, this is where the problem is. You know, in the cities, and we saw that it is higher in the urban centers, where you find children waking up as early as 5 a.m., starting to move to school. Their bags are packed with drinks, soft drinks. And even if it is tea that they are being provided for, the sugar content is like that. So definitely, if children are fed on these sweetens, definitely it will affect their health. That is why maybe obesity is also increasing in the urban areas. Because in the urban areas, the mother and the father are both busy. And nobody has time for these children. And they go to school, the canteens are also filled with some of these sweetened beverages. And vegetables, if you have 31%, close to a third, not given at all, then it is serious. Now the question is, all the food types, the fruits are more costly. Fruits and vegetables are more costly. So how do we work out to ensure that that type of food that is good for our children and ourselves are made to be less costly? And maybe we need to work with the Ministry of Food and Agriculture so that, like in the olden days, when we are talking about Operation Feed Yourself in our homes, we go back there to ensure that if even we, the adults, will not take vegetables and fruits, we will not deny the children of this healthy food. Again, let me emphasize this point again on healthy food consumption also being higher in urban areas compared to the rural areas. And yet we pride ourselves that in the urban areas we are the more educated. We are richer. We are more enlightened. And yet the unhealthy food consumption is higher. So we need to explore and find out. Maybe because you are leaving home at 5 a.m., you are unable to prepare any healthy food. You go to the fast food and it's full of oil. Then you live sedentary lives. From your air-conditioned car into your air-conditioned office, back to it, And some even at home, they run into air-conditioned bedrooms. So they don't sweat. They don't do any exercise. Obesity increases. And non-communicable diseases like diabetes take over. So we need to look at it also quite well. All right. There are a lot of things that I wrote here, but let me skip this one and then touch briefly on. But before I move to child health, let me talk about nutritional status of adults, where the report shows 50% of women of age 20 to 49 years being overweight or obese. That is half. And that hit me. So we need to be careful about this. When you compare it to the 15 to 19-year-olds, it is lower. So why is it that when we are growing, then obesity and overweight is also increasing? Is it because we are not under the tutelage of school tutors who maybe have timetable for exercises, sports in schools? And when we grow and we are on our own, then we misbehave. Forget about the instructions that we had. So we need to ensure that those exercises that we do in schools, we train our children to grow with them, so that when we are aging, we become less and less obese. And anemia in children, what also amazed me was those, when it comes to child health, those children who had fever. We have about 43% of them who never sought any treatment or any advice. Now the question is, what happened? Was it because they were helpless, or they have no knowledge as to how to go about it? When it comes to those who had diarrhea, we have 49% who never sought treatment. That is, the mothers didn't seek treatment for them. And that, for me, is something that we need to be worried about. In terms of children below 5 years who have symptoms of acute respiratory infection in the 2 weeks before the survey, 46% of them had no treatment sought. So now we need to find out why this is happening. And so even though the report as it is do not give us those nitty-gritties as to why this is happening, as researchers, we need to maybe delve deeper into the data and see what we can cross-tabulate against what to be able to help us maybe have some plausible reasons why they are as they have been reported. On vaccination, I thought some time ago, Ghana Health Service was giving us vaccination coverage over 100%. And that has been a source of worry, and then I think GSS is trying to find out, working with Ghana Health Service, why we have such situations happening. But when you look at the report that is being given, of course, this one is giving us retrospective information as to what has happened in the past. And when you have it, you are in the field and doing it, the results may be different. So we find that 75% of children 12 to 23 months were fully vaccinated against all basic antigens. So the 25%, what happened? So while we are priding ourselves that we are improving, that is good. The little that is not getting there, we need to explore and find out, because the standard should be the highest. And not that we have moved from point 1 to point 2 and that's we are fine. And it has taken some of the indicators 29 years to move some 5 percentage points to where we are. And I think that is where we need to draw attention and work harder going forward so that we are able to achieve the standard that everybody is gearing at, especially based on the SDGs. So to conclude, yes, the indicators that we have seen, some are beautiful. And it shows that some work has been done. It shows that we shouldn't always be complaining. Times in Ghana, we hear more of complaints than where areas that we are doing well. Especially when Black Stars go to play a match like they have done. Everybody forgets about everything. But at least when we forget about them a little and look into the DHS report, it shows that some good things are happening. There are still gaps, but we need to work towards it. So thank you very much. And I believe that we will take note of all the gaps, the regional variations, the gender variations, the urban-rural variations, and work towards closing these gaps. Thank you very much.
Thank you so much, Prof. Kwanche. It's now time for us to share our opinions and ask questions. May I ask Dr. Fofie and Dr. Boateng to join us in the front? There are mics in the aisle, so if you have a remark or you have a question, you can just use one of them. You give us your name, then where you're coming from, and then your question or your remark. Thank you. So take a few questions. Yes, please.
Go? All right.
Okay, good afternoon. My name is Grace Hamwa Asari. I work with TV3 and 3FM. So my first question, Dr. Fofie, I heard you say that CS is increasing in the urban areas. I think last year, I read a paper that said that women in urban areas are voluntarily opting for CS because they want to protect, or they don't want to deface how their sex organ looks, or they don't want to loosen how their sex organ is. Did this reason come up? Are women voluntarily opting for it? That's why it's increasing, or there are other reasons? The second question is, does a survey give recommendations on what you find? I'm asking this question because of the figures that came out from cervical cancer. We know this January is a month for cervical cancer education, and if we have only 5% of Ghanaian women having been tested for cervical cancer, then it's a worry. Do you make recommendations on what we should do going forward, especially in that area? My third one is about exclusive breastfeeding reducing. It's not a question, it's a comment. Women have 3 months maternity leave. In fact, when you are 2 months and 2 weeks old at home, your HR sends you a message. How are you? Is baby fine? To tell you that you are resuming work in 2 weeks, so you better prepare and come back. If we are to breastfeed our babies for 6 months exclusively, but we are going back to work after 3 months, how do we do it? No mother will say, I have to breastfeed my baby for 6 months, but I want to add whatever to it. If we want to see proper change in that area, it must start from Parliament. Ghana Health Service, write a letter to Parliament and tell them that at least give us 4 or 5 months, something close to 6 months. I'm a new mom, and this thing, it hits me so much. I couldn't understand it. If you want to see breastfeeding increase, let's start from there. 3 months, dear, is sadodo. Too much.
May I? Good afternoon. My name is Professor Richmond Daite with the University of Ghana School of Public Health. And I want to applaud you for that advocacy. I think it's very good. And I wish what you said about 3 months is even that. It's not 3 months. It's actually less than 3 months. It's 12 weeks. We want more. So I would like to add my voice to that, associate with that. But the issue I want to raise has to do with the fact that some of the outcomes that we are seeing is not only the result of people's behavior. There are also structural issues that drive these outcomes. And I'll pick on the issue of overweight and obesity. I think that's the one that has really caught attention in the media. And since the media is here, it's important for everyone to understand that it's not just because people eat, that's why they become overweight. It's not even also because they do not carry out, they are not active. That's part of it. But there's something more than that that I think a lot of us are not putting our minds to. And that is the structural changes that are occurring in our food system and also in our food environment. Now, let me explain that. Have you thought about why a lot of the conversation that we are having is about women's overweight? And that is now 50%. In 2014, it was 40%. By the way, I'm not surprised at the current estimate because the trajectory was going towards that. Men's rate was around 16% in 2014. It's also increasing in men. Now, that tells me that it's not just about women and it's also not just about food. Something is happening in the kind of food that is available that people have access to. Something is also happening in our activities and the use of technology and all the things that determine how we move. Really, Ghanaians, we are not moving. Those days where if you are going from here to stadium, you would walk. Now you would just hail a cab and go. In your own house, there are gadgets that are doing almost everything for you. By the way, it's not only in Accra. It's also everywhere around the country. So let's not think only about the behavioral part of it. If we do that, we will miss the point. There is also the issues around structural changes that are occurring in our society. Those dynamic changes, we need to start thinking about how to address them. Thank you.
Thank you. I'm Oswald with Coalition of NGOs in Health. My question goes to Dr. Fofie regarding the initiation of breastfeeding within the first hour. That's around 50%. I stand to be corrected with the exact figure. As rose to around 80% within 2 days. One could clearly see a possible confounding effect over there. That's the period of recovery, for instance, because it's not a question of attitude that a mother wouldn't breastfeed the child within the first hour, but then within the 2 days period, the figure rose. Coming back to the same explanation that most women opt for CS, definitely it prolongs the period for recovery as well as possible postpartum complications. May I know the quality measures that have been put in place to shorten the period of recovery for mothers? Because as compared to the first hour, around 50%, and that of the 80% in the 2 days, you could see the clear change in the number of mothers being able to breastfeed their children within the 2 days. So what is the possible quality measures in place to shorten the recovery period for mothers? Thank you.
Okay, thank you very much for the opportunity, and thanks to all the presenters for the insightful presentations. My name is Dr. Nazir Tanku Mohammed. I'm with the Expanded Program on Immunization Ghana Health Service. And I'd like to take the opportunity to thank Ghana Statistical Service for actually churning out these data for us. I think Prof mentioned that the data sometimes, the administrative data that sometimes we share is usually higher than what we are seeing. Of course, challenges that are associated with administrative data. And so this actually comes in handy to help direct the program where to focus the little resources available, and we are very grateful for that. The little input I would like to make is with regards to the definition of the fully immunized child per the national policy. I think we projected the antigens that a child should have received by age 1 to include 4 doses of OPV per the national schedule. And I would like to make a contribution that the national policy says 3 doses of the OPV, just like we use for the basic antigen. The first dose that we are giving at birth is just an additional opportunity we are giving to the children. And usually after 2 weeks, if the child does not receive it, we do not give it anymore. We now concentrate on what we give from 6 weeks, 10 weeks, and 14 weeks. Then also, I think we are still capturing 2 doses for, Ruta vaccine. Currently, we are doing 3 doses right from 2020. We switched from the two doses that we are doing to 3 doses. So maybe if we update it, it may reflect what we did better. Thank you very much.
Yes. Hello.
Hello. Okay. Yes.
Thank you very much. My name is Divine Atupra, or Dr. Divine Atupra. I work with UNFPA. I want to say thank you to all the presenters, Dr. Fofie, GSS, and other presenters. My concern really has been that most of the indicators that actually were shown today were very good, and we are all happy with that. But then these are mostly, coverage indicators or access indicators that we all know. And the purpose of this is for us to be able to get to, where really we want to get to. That is, how well is the mothers doing when they go to deliver. And we all know that the maternal mortality is still not very good. We don't have that one here, but then we know from our institutional, rates, and then from the census that we had in the past, that is still not very good. Now, my question and my comment, to Ghana Health Service and everybody is, how do we, bridge this gap? I think that, the main challenge has to do with issues of quality, and then the assets that we are talking of really, does not really come as assets, because, where we expect to have some of the services to be free are really not free. Mothers go to the facilities, with NHIS card, and they are told that for this service, you will pay, for this one, it is free. And so I think we need to see how best we could bridge the gap between the actual goal that we want to achieve, that is the well-being of mothers, reducing maternal mortality, and then also making sure that children grow well. And, the gap between that one and the coverage indicators that we are taking. Thank you very much.
Thank you. Dr. Fofie, could you please address it?
Yes, I should go up. Yes, thank you very much for the insightful questions, and I'll start with the Syrian section 1. Yes, indeed, Syrian section rates have increased. As we speak now, we're talking about 1 out of every 5 women in Ghana delivers by Syrian section. And you're trying to find out what are the possible reasons, right? During this research, the survey, we didn't go into the reasons why women opt for. And we want to encourage any researcher to support us in getting an in-depth information in that area. That will help us to see what will be. But there are general concerns about the increasing Syrian section rates. We're looking at, are there a correlation between Syrian section rate and maternal and child health or newborn outcomes? as we speak now, it doesn't appear to be. And these are the concern areas. One thing that we see clearly here is a new definition, or is it maternal request? That's where you are alluding to. Like in medical practice, cesarean sections have specific indications, maternal indications, newborn or child indications where cesarean sections should be done. But now we have a very huge number of women coming for maternal requests. They request for it, and majority of the time after the first cesarean section, then they get second cesarean section and third. All are just repeated cesarean section, and that is one thing that is bloating the number of cesarean sections that we need. So we assume, and here I say assume because we've not conducted any major research in that area, that birth, labor analgesia could be a contributory factor, that those going through cesarean section get extensive pain relief, and therefore they don't tend to feel much, as against those going for vaginal delivery, the contractions and all that. Every 2-3 minutes you have a contraction and have to wail like crazy before. So we just think that if we're able to improve labor analgesia, that might help to get women a bit interested in vaginal delivery, as against the rise in cesarean section. So these are all options that we're exploring, and think we might be able to find a way to first of all establish the linkage and make sure that those who get cesarean section are those who need them, and that will inure to the benefit of the mothers and the newborn. So that is it on the cesarean section. The second is on the cervical cancer. I agree entirely with you. Cervical cancer is sexually transmitted disease, infection, right? It's all coming from papilloma virus, and therefore one way to solve that is to be able to put in structures to, first of all, we can go ahead with some vaccination. We can look in that direction when you ask about suggestion for our girls, so that in future they won't be infected at all with human papilloma virus, and therefore their risk of contracting cervical cancer, the infection and cervical cancer will reduce. Apart from that, we could have a program, a national program where all women within reproductive age could be screened for pre-cancer lesions. And whenever we identify, we can treat those pre-cancer lesions and prevent cervical cancer from happening. So there are known interventions. There is a group already, and I'm referring to Dr. Ifa and his team at Bato have done extensive work in that area. We are looking at how those cost-effective interventions that they've pioneered can be put into national contests to guide a national program where all women can benefit from screening and prevent cancer from happening. So that is it in that area. Then the last is the breastfeeding, right? I think as for the breastfeeding, for now, I think you've charted a good path. Let's get parliamentarians, let's get society, let's get media, all in advocacy to see how we can widen the space. But in the interim, what we are suggesting from Ghana Health Service is that all workplaces have at least a space for a breastfeeding corner, an area, so that the working mothers can openly or comfortably breastfeed within the confines of the work, as we work on the general principles of changing the policy and the law around maternity leave. So that one, I think, is our battle together, and we'll move in that direction. Yes, apart from that, I think the early initiation, good. The early initiation, the first thing we identify here, what we're saying is that we know that when women initiate breastfeeding, when babies are initiated within the first hour, there is a likelihood that that intervention will continue. They will establish breastfeeding, and that will be to the advantage of the newborn. But as we speak, you mentioned that it's possible that there are issues around the recovery time and all that. Any woman who delivers, like vaginal delivery, there's enough evidence to support that. During delivery, even when baby comes out, immediately breastfeeding can be initiated. So there is no need for any special recovery period for initiation to start. Baby is removed from perineum and placed on the abdomen of the mother, and straight away baby can be put to breast. Again, we mentioned cesarean section. What can we do to? Yes, there I think you have a point. Majority of the time when you perform cesarean section as a practitioner, before even you finish surgery and get to the ward, baby has been started with some formula of the sort. These are gaps we have in our system, which it doesn't have to be so. We're saying that even for cesarean section, there are practical interventions that we can put in. Now that we have about 1/5 of our deliveries being cesarean section, that is a huge number. So it's about putting in algorithms, and we've started work in that direction to have guidelines on how to handle deliveries from cesarean section in terms of early initiation. Cesarean section, initiation can start in the theater. Again, giving good analgesia to the mother can help her to be able to sit after 6 hours after delivery. A lot of them with good analgesia are able to mobilize and breastfeed. And I think there could be some few examples here who have been able to initiate breastfeeding. When analgesia is poor, then women are unlikely to be able to mobilize and are unlikely to be able to sit and breastfeed. So these are a few of the areas we've identified. We'll explore that, probably research further into it, and have specific interventions that we can use to be able to improve early initiation and breastfeeding in general. I think these are the areas. And in that bit, I think one last thing that I want to mention here is that UNICEF has been quite paramount in that regard, supporting us in activities in that area. Dr. Kwatin, if he's listening to me, will be coming to you once again to see how we can address issues there and propel this whole agenda of early initiation to a very conclusive end. Thank you very much.
Thank you. A last round of questions or comments before we go for snack break. Okay, since there are no comments, we'll take a 20-minute snack break. Let's do that after the snack break, please. So we'll take 20-minute snack break, and then we'll come back for the second session. Thank you. Presentation on infant and child mortality, and that will be done by Mr. Odejebi, Director, Demography, Ghana Statistical Service. Let's welcome him.
Greetings to you once again. My name is Godwin Odejebi, and I am presenting on infant and child mortality. So for the highlights, it will just be on the key findings. Then I will look at the status as far as the childhood mortality is concerned. Then we will look at what are the main issues driving child mortality in Ghana. Then we have some takeaways. So we're working with the global goals as well as the health sector medium-term development plan. That is for 2022 to 2025. So once the DHS is in 2022, we'll be able to measure whether we are achieving some of our development plans as far as the health sector is concerned. Then also whether where we are now, we'll be able to achieve the global goals. So for the highlights, we start with our status, but then we look at a few concepts. Basically, the neonatal, which is the probability of dying before once reaching the first month of life. Another concept too is the post-neonatal. That one deals with the probability of dying between 1 month and the first birthday. Then we have the infant mortality, which is for deaths occurring under 1. So that one is the probability of dying before the first birthday. We also come across child mortality. That one is for children between the age of 1 and 5. We're looking at their mortality situation. And then the under 5 mortality, that is the probability of dying before reaching the 5th birthday. So what is our situation as far as the 2022 GDHS is concerned? So for the neonatal mortality, the figure is 17 deaths per 1,000 live births. And when we look at it in terms of the health sector medium term, which had a target of 24, meaning that Ghana, we've been able to achieve that target as far as the medium term is concerned. But you know very well that for 2030, as we're measuring the neonatal for the SDG, for that one, it's looking for 12 deaths per 1,000 live births. The issue is, by the time we get to the 2030, are we able to achieve that particular target, looking at how we are moving? Then we also have the post-neonatal one, which stands at 11 deaths per 1,000 live births. For the infant, it is 28 deaths per 1,000 live births. Then the child is 12, and for the under 5 too is 40. Then the health sector medium-term target is 55 deaths per 1,000 live births. So when we take all the medium-term indicators for this childhood mortality, it's like we have achieved Ghana, taking into consideration the target for 2022. Now, we've moved from somewhere before getting to the 2022. So if you look at for 2003, the under 5 mortality was 111. It has moved down to 40, meaning that for a period of 19 years or so, yes, we've been able to somehow more than half the under 5 mortality per the numbering presented here. Equally, for the infant mortality, we moved from 64 deaths per 1,000 live births in 2003 to 28. And for the neonatal, we were 43 deaths per 1,000 live births in 2003, but now it is 17, as I mentioned earlier. So this is the journey which we've traveled from 2003, 2008, 2014, and 2022. This is how we have been able to perform as far as the childhood mortality indicators are concerned. Even though we've done well, but when we go down to the regions, there are variations. Some are below the target, some are also above the target. So, and then if you look at the trend too, some have been able to move sharply or drop sharply whilst others too somehow being somehow stagnant, or somehow stagnant. So if you look for the neonatal mortality, OT region had a highest neonatal mortality of 32 deaths per 1,000 live birth. But then if you come down to Greater Accra, which recorded the lowest of the neonatal mortality, stands at 10 deaths per 1,000 live births. So you see that even though when you take the whole country into consideration, but then at the geographical level, there are variation, there are differences. Some are doing well, some are also not doing well. And also, for here is for the under 5 at the regional level too. The same vein, OT tops the ladder with 72 deaths per 1,000 live births. And Greater Accra recorded the lowest. And when we look at OT, it has moved down from 134 to 72. So that is how it has traveled. There are others too, even though it has all come down, but sometimes the slope is different, and that is a clear indication of all the regions not performing at the same level. So, having presented the figures to you, we move ahead to see what is actually driving this childhood mortality. So we start with childhood mortality by mother's age at birth. So for those less than 20 years, mothers less than 20 years, we have a neonatal mortality of 27 deaths per 1,000 live births. And then also for those 40 to 49, also recording 30 deaths per 1,000 live births. So we see that between 20 and 39 years for the mothers, neonatal mortality is lower. Equally, when we go to the under 5 mortality is the same way. Early births or mothers less than 20 years have high mortality of 65 deaths per 1,000 live births. Then between 20 and 39, we have 40 deaths per 1,000 live births. Then again, when we move to 40 to 49, it's 52 deaths per 1,000 live births. So these are the situations. So you see that mother's age has influence on child or on what is called neonatal mortality, and then also for under 5 mortality. So by residence, urban, rural, what is the situation? For the neonatal, it is 17 for rural and 17 for urban. So whether you live in a rural area or not, it's the same neonatal mortality. However, there are differences when you take the under 5 mortality into consideration, where for the urban it's lower than that of the rural. Urban recording 37 deaths per 1,000 live births, whilst the rural have a higher rate of 42 deaths per 1,000 live births. So this is the situation. I think this morning there has been much talk about the relationship between education and our indicators, where a bit higher schooling has effect on some of these indicators. It has also featured prominently over here with regards to the childhood mortality and mothers' education. So for neonatal, it is those with no education and primary education, the rate is 19 deaths per 1,000 live births. And then also for secondary is 20. But then those with more than secondary education, you've seen that neonatal mortality has dropped up to a lower figure of 8. So if you look at the level of education of the mother, it has impact on neonatal mortality. Again, for the under 5, those with no education and primary education recorded a figure of 52 deaths per 1,000 live births. Then it moved down for secondary to 39, and those more than secondary dropping to 19 deaths per 1,000. So this is the issue which relates to what was made in the morning, that higher education means improvement in our indicators. So, and it is clearly shown over here that there is a relationship between level of education and then under 5 mortality. Again, for the wealth quintile, those are for neonatal, those are the lowest quintile. We having 22, and then as you move to the ladder to the highest level of wealth, it drops down to 12 deaths per 1,000 live births. So for those with at the highest quintile, you see that it's like they have somehow achieved our SDG for neonatal of 12 deaths per 1,000 live births. Then let's move on to the under 5 mortality and what is the situation over there. For those with, those are the lowest quintile, recorded 56 deaths per 1,000 live births. Then it dropped to 46 for the second level. But then for the middle, we saw an increase to 48 deaths per 1,000 live births. And from then, from the 4th to the highest quintile, it moved down to a lowest of 25 deaths per 1,000 live births if you fall within the highest wealth quintile. I think birth order too is critical in terms of childhood mortality. For the birth interval of 1, we recorded 20 deaths per 1,000 live births. But for those 2 to 3, yes, it's about 13. It moved to 23 for 4 to 6, and then plus 7 is 26. So you see that for the birth order, if we have a lower birth order, the mortality, neonatal mortality is low compared to a higher birth order. The same way for the under 5 mortality too, we see a birth order 1 has a mortality, under 5 mortality of 46 deaths per 1,000 live births. Then it went down to 37 before moving to 48 and 51 for birth order 4 to 6 and 7 respectively. Yes, here is about previous birth interval. And for an interval of less than 2 years, we see a higher neonatal deaths of 29 per 1,000 live births. Then 2 years, we recorded 16. 3 years, the figure was 15. And then 4 years plus is 18. So when we go to the under 5 mortality, a birth interval of less than 2 years, there has a higher under 5 mortality of 77 deaths per 1,000 live births. But as we move to the ladder, it dropped to 37 for 2 years. Then it further dropped to 32 for 3 years. But for 4 years and over, it moved up to 38 deaths per 1,000 live births. So, as we have gone through, the takeaway messages is the childhood mortality has declined. If we take into consideration the period from 2003 to 2022, we witnessed a decline. The neonatal mortality rate is 17 deaths per 1,000 live births, and the under 5 mortality rate is 40 deaths per 1,000 live births. Childhood mortality is higher among children born less than 2 years after a previous birth. Then again, there are regional variations across mortality indicators. Then when we take the mother's age at birth, residence, education, wealth, birth order, birth interval, they remain key drivers in addressing mortality or childhood mortality. So if we want to further decrease the childhood mortality, these are some of the areas we need to look critically so that we'll be able to reduce the childhood mortality which we have in the country. Then achieving the Sustainable Development Goals 2, 3, and 5 targets will require acceleration of efforts and investment. So I think on this note, I end my presentation here, and thank you very much for your attention.
Thank you, Mr. JB. Our next presentation is on malaria, and would invite Dr. Nanaya Pepra from the National Malaria Elimination Program.
And that was very smart. I saw control on the program, and she rightly mentioned elimination, because we are no more talking control. Now we are looking at elimination. Elimination basically doesn't mean that we are in elimination, but it's a focus of the country. And it's that core where we are looking at, by 2028, at least having 21 districts moving to elimination, and by 2028, having mortalities related to malaria being near zero, then hopefully reduce incidence by 50%. And so we are actually an elimination program now. Thank you, Francisca. So I think it is important for us not just to think about elimination when we are not looking at data. And that is why this survey is very important to us, because it's able to guide us on the gaps we have and how we can improve on the issues with malaria and be able to achieve elimination. So I will just highlight some of the findings on the coverages of the various services we have, and then look at the status of the malaria parasite prevalence, and then we leave you with a slide on some key findings. So as a program, we have a number of malaria preventive interventions, and I'm sure you can start from insecticide-treated nets. You can talk about indoor residual spraying, of course, the larval source management, where we kill the baby mosquitoes. But with this presentation, I'll quickly look at the ownership of the nets. Over the years, we have seen an increase in the ownership of nets from 42% in 2008 to 74% in 2019. And then it dropped to 67% in 2022. And this could be with the background that in our last mass campaign, we limited the distribution of nets in some urban areas. And this was with the fact that over the years, we have seen that net use in urban areas were a bit reduced. And so we've been looking at what other interventions should we use in urban areas to ensure that we achieve the goals
for elimination. And that is why you see a lot of larval source management in urban areas. And that is one of the reasons why we limited the distribution of nets in 2021, which showed the reduction. It is also important to note that even though people own nets, if you move into the discussion per residence, you realize that those in the rural areas own more nets than those in the urban areas. And we also looked at whether the nets they have are the insecticide-treated nets, which are able to kill the mosquitoes, or they are nets that are not treated. And if you look at the data on any mosquito net, it's similar to the data on any insecticide net, which means that the nets people have in their households are the insecticides-treated nets. If we look at ownership by wealth, we realize that households that are wealthier seems to have less nets. And that is understandable also because wealthier households tend to have the means to get other interventions like the indoor residual spraying, like the larval source management, and in some sense too, they get to have less malaria, and so the need to even sleep under a net also reduces. And this could be some few reasons why the wealthier population or household seems to have less nets. If you look at ownership by region, you realize that OT region recorded the highest, followed by Volta region, and Greater Accra, as always, recorded the lowest. And one of the important discussions with nets is not just about ownership, but it's about access and use. Because if you have the net and you're not using it, it's not going to achieve the purpose for which the nets have been distributed. And when we talk about access, we are basically looking at least one net for 2 persons in a household. That means that household has access. And if you look at the gap, 61% of household population had access to nets, and yet 40% slept under the net. The gap even increases when you look at the urban picture. So those in the urban areas, even though they have access to the nets, they are not using the net. And this gap from 2014 has almost been the same. So even though we are putting together behavioral change communication strategies, we still see that some proportion of the people are not using the net. And that is why it has been important that together with stakeholders, we think about the other interventions that are necessary for use in the urban areas, especially to address the vectorial capacity issues. If you also look at the children under 5 and pregnant women who slept under the nets among all households, that was 49% for children under 5 and 48% for pregnant women. If you look at those households with at least one net, it increased to 62% and then 60% for pregnant women, which means that when people really have access, some will use, but some are also not using. So there's still the opportunity for us to look at what the issues are. Those who want to use it, why are they not using it? I remember some of the surveys, the 2019 survey, were able to identify a few reasons which we have been addressing over the period. And if you look at the trend for children who sleep under the nets, from 2019 to 2022, it had decreased from 54% to 49%. And that of the pregnant women also decreased from 49% to 48%. And the use of net among children under 5 by region, you also realize that OT region recorded the highest net use among children under 5, and Greater Accra recorded the lowest. For pregnant women, Ahafo recorded 72%, that's the highest, and once again, Greater Accra recorded the lowest. And I believe that this is just telling us a story about the discussion of net use and how stakeholders will have to come together to really look into the issues of net use and the other options we have available. Now, as one of our preventive interventions for pregnant women, any pregnant woman who goes to that facility for the first time after registration, we expect that at 16 weeks of gestation, you are given a medicine called sulfadoxine pyrimethamine. And when you take this medicine, it is supposed to prevent malaria in pregnancy and reduce the chances of anemia in pregnancy and the issues that come with the childbirth. So we do this every month from 16 weeks up to delivery. And it was good that we were able to monitor that. You realize that in 2022, IPT1, which is the first medicine the pregnant one takes at 16 weeks, was 90%, which is a slight reduction from 91%. And then IPT2 was 77%, which is also a reduction from 80% from the previous year. And then IPT3, which is a third dose the pregnant one takes, also slightly decreased from 61 to 60%. Now, aside this preventive intervention, the most important thing, one of the important things also is for us to treat every positive case. So it's expected that if you have signs and symptoms of malaria, fever, or history of fever, and any other symptoms, you have to be tested. When it is positive, then you are put on treatment. And so we looking at the proportion of children under 5 who had fever. In the 2 weeks prior to the survey, it was just around 50%. And then those proportion that sought for care, and which really is something that we have to discuss, it's just less than 60%. It's something that we have to look at. We have to encourage people that when you have fever, you need to go to the health facilities or the over-the-counter medical sellers or the pharmacies where we have trained people to get you tested. And people really have to seek for care when they have fever. Also, we realized that about 40% of the people had blood samples taken, because when you are testing you, it is either you are taking a blood sample for RDT or for microscopy. Only 40% of them had that taken, and then 40%, the same number, had diagnosis of malaria. And when you are positive, you are expected to be given a medicine called either artesunate amodiaquine or artemether lumefantrine or any of the ACTs, right? And so that is why we're trying to monitor what medications are people giving. You realize that almost about 80% of the people who had fever were given ACT, which is the first line of treatment. If you look at the others, aside Fancida, chloroquine, which I'll come to very soon, the others, there could be some background reasons. For instance, rectal artesunate. In areas where they have to refer the child, they could give rectal artesunate and then refer. And so that could explain why you are seeing rectal artesunate. That could also explain why you are seeing artesunate injection. Because in areas where they also want to refer, or if it's severe malaria, they are advised to start with injection artesunate. But our worry is with the use of Fancida for treatment, because we do not advocate for monotherapy in the treatment of malaria because it doesn't work. And so that is what we really have to look into and look at the areas where these practices are happening. In 2019, we saw a similar thing and realized that it was really happening in the northern region. We did some studies and we found out that it was happening in the over-the-counter medical sellers. We did a lot of advocacy. So this time around, I think it has reduced, but we still have to look at it again and see where the issues are and work to correct it. Chloroquine. We stopped using chloroquine so many years ago because the parasite had developed resistance towards chloroquine. And so then once again, we have to look at why and where these are happening, and then we try to put in interventions. Now, after all the interventions, really, the end product is that, is there malaria or not? And I'm sure that is the most interesting part of it. Aside malaria, malaria contributes to anemia. And so before that, I just want to present some few slides on that. And also kindly note that 97% of all the eligible children were actually tested for the anemia and malaria. And you could see that anemia is also going down from 19% in 2008 to 2% in 2022. Of course, if malaria prevention is going well, anemia will also go well. If you compare this by the wealth quintiles, you realize that the wealthier the household, the less likely you have anemia, and that is also understandable. But before I go into the parasite prevalence or the level of the malaria burden, I just want to explain the differences between the RDT and the microscopy. This is key because for the RDT, which is fast, which we quickly get it done, it is picking what we call the antigens. And for the antigens, even after treating your malaria for within 28 days, the RDT is still likely to be positive. So if you see a patient and you have treated the patient for malaria and the symptoms are gone, even within 28 days, RDT will still be positive. Whilst the microscopy looks directly at the parasites, and that is done by a trained microscopist. And usually the reason for trying to explain this is because the RDT positivity rate you see is usually higher than the microscopy or the slide positivity rate. And exactly as you see over here, you realize that the RDT positivity rate is around 17%, whilst the microscopy, is around 9%. So as a country, if I'm using this as a proxy, if I pick about 100 people, right, I can get parasites in just 9 people out of 100. And this used to be around 28% in 2011. And that is a progress we have made over the years. And because most of our interventions are, if they are under 5, it covers all the under 5. You don't expect to see differences in the breakdown of the under 5. And so that is also understandable. Rightly, as I was saying, 2014, 27 out of 100 children under 5, you will pick out the parasites. And that has decreased over the years. And that is what we are talking about. We are saying that our parasite prevalence is going down. What it means is that gradually we are getting to the point where we will not have the parasites circulating in the population. And that is a point where you say you have reached elimination. And somebody tells me that there are a lot of mosquitoes around. So how can you eliminate malaria? You don't need to eliminate all the mosquitoes to eliminate malaria. All you need to eliminate is to eliminate the parasite to eliminate malaria. And if you look at the parasites by the malaria prevalence by the residents, you will also realize that it is more prevalent in the rural areas than in the urban areas. And the wealthier population also has the less prevalence of malaria parasite. Greater Accra has the lowest, and most districts in Greater Accra actually have very low parasite prevalence. And that is why we are hoping to get at least 21 of the districts in Greater Accra to be moved into elimination by 2028. And OT region has the highest of 15%. And if you had looked at this map about a decade ago, you'll be seeing even a place like Upper West region recording about 53%. And systematically through interventions we have put in place, we have seen that reduce. And that is why we are very encouraged that with all the intervention mix we have available as a country, and with the information we are having from the survey, we should be able to put in strategic interventions to get to our point. So basically, these are the key findings I want to leave with you. The summary really is that there's still a gap between use and access. We need to continue to advance on the barriers that is not helping with the use of intervention, and also look at the other interventions that will be helpful in areas where people are not using the net. And then also, as we appreciate the progress we have made in the malaria positivity rate, we have to look at what other things can be done to achieve our intervention, our aim as a program. Thank you very much for your attention.
Thank you so much. I think we can see that we've made progress towards eliminating malaria in Ghana. There's more for us to do, and I hope by the next release we would have reached our target. We'll now take remarks from the health sector, and once again we call on Mr. Solomon Boama to give us his remarks.
Thank you very much. And thank you, the presenters, for another insight into these useful indicators. So, as I continue to say, as a service, this is our performance. So, any remarks will actually mean that you are re-emphasizing what the presenters have already mentioned. Yet, so what we will continue to appreciate as a service is that we are happy with the findings because this is a population-based finding. And then it actually highlights issues that as a service we are supposed to take on board to ensure that we progress accordingly with our set goals and then targets. So the presentations were clear, and I will say that it is not still different from how it mimics our routine data. With the malaria, the gap in ITN ownership and use is a challenge with the service. And then the usage as well, especially with the age groups we have identified as the vulnerable, the under 5s and then pregnant women. Also, the IPTP intervention, the dropout rates continue to be a challenge. Why women are not able to continue with their doses during the pregnancy. I think it's another challenge. And then it has become evidently clear from the presentation that we need to also still sit up on our pharmacovigilance because as of now, medicines that were not expected to be in the system are still being used as alluded by the presenter. But we want to commend our partners and then the ministry and then our gallant health workers for some of the achievements that we are seeing today. Yes, the decreasing trends in the malaria, both the case fatality and the prevalence, and also the decreasing trends in anemia and the others. I think these are all efforts that were put together by our stakeholders and us. For the childhood mortality rates, yes, there's a significant success that can be mentioned. Yes, but there was a question that was posed during the presentation that can we maintain this pace of performance to achieve the Sustainable Development Goals? I think it comes down to all of us to put our heads together as stakeholders in health to ensure that we progress according to our targets. It was also evident that though nationally we seem to be doing well, there were still some regional variations. And that will require some bit of investigations to find out the reason why, apart from some basic facts, other regions are doing well and then others are not. So that this could inform some targeted interventions. I think that is a good way to go. I'm particularly happy about the detailed analysis with the segregation of the data to its lowest bit. That will help partners, donors, and other agencies who would want to concentrate on any part of the intervention to hit it right so that we don't run in circles, not achieving what would want to do. Yes. So I would not want to reiterate the the coverages, because for us, Ghana Health Service, this is our work. And then we want to just appreciate the effort by Ghana Statistical Service to let us know the details of what we are doing so that it will direct our efforts with other stakeholders to achieve what we want to achieve. So on this note, what I'll continue to ask or advocate for is that the drivers for performance or achieving the Sustainable Development Goals and other targets that we envision does not just lie with the Ghana Health Service. We need a multifaceted effort to make sure that the indicators we are seeing today will be a different story with another GSS. So we thank you very much for such revelations to us as a service. We'll continue to put in our efforts, and then we invite all like-minded stakeholders to come together to help us achieve health for all for Ghana. Thank you very much.
Thank you, Mr. Wama. We'll now take remarks from academia, and we'll call on Prof. Kwanchi.
Once again, thank you very much for the opportunity. In the morning, the room was almost filled, but in the afternoon, many are gone. I think after taking the snack, they are gone. Okay, let me talk briefly about infant and child mortality and some of the reports that were highlighted, the indicators. Quite clearly, you can see that we are having declining infant and child mortality made up of neonatal mortality, infant, child, and under 5 mortality, which is good. So you can see that if you're able to address neonatal mortality, we'll do better than we are doing. I want to highlight one relevant point that came out quite clearly in the presentation about the inverse relationship between mother's education and childhood mortality. And to emphasize the point that even though there's this general relationship, little education is bad. Because for some of the indicators that were shown, when you compare mothers with no education and mothers with primary education, there's no difference. So the education they undertook was wasted. It didn't add any positive thing to what we expect from them. And so let's say education is not good. So let no one drop out. There was something on perinatal mortality which was not presented. But from the report, you see that women with primary education even had higher perinatal mortality compared to those without education. And so that suggests that when you are going for education, go to the fullest extent so that you get the maximum impact. Little education is not good. Again, it also reveals the relationship with the wealth status of the household. So money is good. When you have money, you can achieve something better. And so efforts at improving the economic well-being of the population should be something which must be considered as a priority. As for the regional disparities, the earlier speaker has spoken about it, and the presenters also highlighted them. With OT region, for example, being the champion when it comes to some of the indicators that have been highlighted. And so we need to address those ones. And they are one of the newest regions. So perhaps efforts should be marshaled to address those challenges. Another thing that I want to bring out for us to look at is fertility behavior of mothers and their relationship with infant and child mortality. And here you can see that all the indicators suggested that if you give birth too early, mortality is high. And so mothers who were giving birth below 18, the mortality of their infants was higher. And then at shorter intervals also create higher mortality. And at the same time, when it is too late, that also is bad. And if you also have too many, and therefore the slogan should be that birth should not be too early, it shouldn't be too close, it shouldn't be too late, and it shouldn't be too many. And so when we are talking about infant and child mortality, we need to also relate it to our fertility behavior. And the two go hand in hand. And also, when we see that mortality, infant mortality is also going down, family planning programmers should also pick this up to strengthen the kind of messages that they give to their audiences. Because once you are assured that the children that you give birth to will live, there's no point having too many, because it's a rational way of reasoning. All of them are going to survive. Then let me make as many as I can, so that if some die, some will remain. But here's the situation. Almost all of them are surviving. So there's no motivation to have too many. So that is a strong point that I want to bring out to family planning program implementers, so that they can look at it. So it's a boost for them to achieve more, so that where we have stagnated in terms of our family planning usage, we'll be able to do better and move it forward. Malaria. It's heartwarming that malaria is gradually being eliminated, and that is the target. And when I heard Fancida and chloroquine being mentioned as some of the medications being given, I was wondering whether they are still in the system. Because several years ago, I was nearly killed by both of them. I had taken Fancida, I went to the hospital, then I reported that I had taken Fancida, and the doctor administered chloroquine injection. I came home, I woke up in the hospital with drips on me. So anytime I hear Fancida, chloroquine, I don't want to get anywhere closer. So I'm happy to hear that it is no longer being encouraged or prescribed. An interesting thing that I picked about the gap between ITN ownership and use, and how it varies across the regions, and also by education and wealth status. I'm wondering whether we are not overemphasizing this ITN thing. Because in many homes, especially the rich and the affluent, the educated, we know that it's mosquito that brings it. So what people have is that the whole house is netted. There are mosquito trapdoors also there. So is it not a thinking that when you have all these there, then you don't think of owning or using an ITN? Because personally, when I sleep under mosquito net, I suffocate, because I see myself imprisoned. And at times when I was younger, anytime I saw somebody like that, then I related it to a corpse. And so psychologically, it is not too pleasing to many people. Using myself as an example, maybe I'm biased. But the fact is that when you have the whole house netted, preventing mosquitoes from entering, and there are mosquito trapdoors, why do you go and sleep under ITN? So perhaps that is what is causing it. And Accra, Greater Accra region, is having the lowest use. And those who are more wealthy are using it less. Those who are more educated are also using it less. So these are the relationships that I'm trying to paint and to suggest that maybe it is not just the thinking that some people have it and they are not using. Maybe they are in homes that they consider as secure and therefore no need to use some of these ITNs. In terms of the prevalence of fever and going for treatment, a similar thing we saw earlier, because the report suggests that 50% of children under age 5 had a fever in the 2 weeks before the survey, and advice or treatment was sought for 57% of these children. The 43, there was nothing. So this brings in the issue of attitude of the mothers, or again, maybe money. At times when you don't have money, it is like you don't have taste. And so money is also very, very important. And the 40% that had the blood taken for testing, and the other 60%, I'm always interested in those who did not. And so if 40 had and 60 didn't, that means that there's a big gap that we need to look at. The 9% malaria prevalence that was recorded, having gone down from 27% in 2014 to 9% in 2022, is heartwarming. Because as for malaria, it is everywhere. And I think that the attitude, see, when you live with certain things for so long, you are no longer afraid. Because the average Ghanaian will have malaria until the person is broken down. He will not go to hospital to seek treatment. Because it has been with us in the environment, and we have seen people getting it and recovering without taking any medication. And so we need to conscientize ourselves so that as we work towards their elimination, when it strikes, then we try to find treatment to get it done. So overall, you can see, as I said earlier on, that we have made some improvements. We need to pay attention to the disparities regionally or spatially. We need to look at education and wealth creation as some of the factors that will help us do better than we are doing. And then, since there are diverse institutions and individuals, organizations involved in the effort towards addressing some of these health-related challenges that we have looked this morning, we think that we have to strengthen this collaboration. And once we focus on that, I'm sure the SDGs that we are targeting will be able to attain them. Thank you very much.
Thank you so much. Today has been very insightful, and we've learned a lot and seen a lot. Some of them, I'll add my own take home. That in getting education, try and get to the highest. And also in giving birth, try not to do it too early, not to do it too late, not to do it too close, and not to have it too many. Thank you very much. Okay, so we'll take a few questions if there are. Yes, sir. Dr. Prepara, could you please join us in the front? Mr. DJB, could you please join us in the front? We can hear you. Could somebody please check the mic?
start having all kinds of feelings, nightmares, itching. We suffered a lot until the Artemether group came to save us. But one of the medicines that was mentioned, which is those ones how do you call it? The Malafan and Co. I wonder because I was advised by my doctor not to take it because I am AS. I'm AS blood type. So he said that all those medicines with that active ingredient in them is not good for us. And so I'm wondering, when they are giving it to pregnant women, do they check, their blood type to ensure that if what the doctor told me was true, some of these women are also not AS blood type and they are giving it to them to prevent malaria? Thank you.
Thank you. Any more questions? Yes.
Okay, thank you very much. And my question goes to Dr. Pepra. Probably looking at the fact that our urban areas are not so much enthused with the use of the mosquito net. And you've already also highlighted that, the larvicidal processes that we are using is what we are paying attention to. And interestingly, when you look at the data, the 21 districts that we are targeting for elimination, most of them, or almost all of them, are in Greater Accra urban areas. Should we actually be concentrating more towards what is really working instead of looking at this net that we are using all our strategies in terms of the communication, but it's not actually yielding much in the urban areas? So that where the rural areas, we are seeing some benefits, or we are seeing the usage of the net being high, then we concentrate on that and also make the maximum impact. Obviously, my understanding also has been that when it comes to malaria, it's the gamut of interventions that are available, using them where the effect is maximum, and then we'll be able to derive the best benefit of them. Indeed, the malaria vaccine is coming on board. We are currently doing it nationally. Very soon, most of the other regions, we are currently doing 7 out of 16 regions with the malaria vaccine. And I'm sure as it trickles down to Greater Accra and the others, then the vision of eliminating malaria in these 21 districts will even be higher. Thank you very much.
Thank you. Any more?
Hello. In this video, I show you.
Okay, Dr. Pepra.
Thank you very much for the questions. So I think the first question had to do with SP. So the sulfadoxine pyrimethamine that is used by pregnant women, the trade names could be fancied or Malafan, any of them. But usually it is contraindicated with those who react to sulfur-containing medicines. And so we screen out for what we call GCSPD deficiency and not necessarily blood group. So I'm sure what the doctor was referring to would be GCSPD deficiency. So every pregnant woman will also have to be screened. But if you look at the level of the food effects across the country and the number of facilities with the needed tools to do that screening, we first start with a verbal screen where the midwives will ask the pregnant woman, have you reacted to any sulfur-containing medicines? Do you react to beans or any other medication? And then if that is positive, they go to the actual quantification of the food effect. If the pregnant woman has a food effect, we advise that the pregnant woman is not giving SP. And so the SP, the fancy that we are talking about, is only given for prevention and not for treatment. And it's also not giving a GCSPD food effect and not AS or any different blood group. Issues of what really works in urban areas, rightly as you said, is an issue of intervention mix. What we are now looking at is to focus on the slum areas in urban areas. In some urban areas, there are some pockets of places where malaria prevalence is very high. And so those areas, if the net use is still high in those areas, we could still do net use in those areas. But in the other areas, I did mention lava source management. We are looking at environmental management in general in urban areas. There are some people in urban areas who also have the money to spray their rooms with what we call the indoor residual spraying, and we encourage that as well. Very soon, we'll be introducing a new intervention in the urban areas, especially for the 21 districts, what we call the mass drug administration, where we are trying to clear the parasites in the system. So we agree with you. What we are trying to look at now is look at what really works and how do we combine the various interventions we have available to address the issues in the urban areas. Thank you.
Thank you so much. We have gradually come close to the end of our dissemination. And at this point, I will invite Dr. Faustina Frimpong-Engwa to give us her closing remarks.
Thank you so much. And we are very grateful to you who have stayed with us till this time. I think I revised my notes, so the next time all presentations will flow before we have our discussion so that they don't run away after their snack and leave us. But it's heartwarming that we have all of us in here just to ponder and go through what we are discussing because it's important to all of us. I was asked the question that are people using data now than they used to do? And I think that I will applaud the media houses because now the media houses will pin down even those people they are interviewing to give them facts and figures. And therefore, for us, we think that there's been a change and we are moving in the right direction. Again, we don't want to stay at our comfort zone of just pushing out figures. But with this form of dissemination, we'll bring it close to the users so that they'll be able to interrogate it and use the way as they want. For today's theme, there are a few things that take away, sticking with me, and I still want to stress them. When you look at all the other indicators, we're doing better, we're progressing. Maternal mortality is still something that we are way over the roof. Even in their media review target, they are looking at, is it 298? Meanwhile, the SDG is telling us that by 2030, it should be at 70 maternal deaths per 100,000 live births. And if you look at what our indicators are showing down, then it means a long way to go. What are we doing to ensure that we'll bring it down, or what steps do you want to put in place to ensure that we really tackle this one head on? Based on this, one of the few things I want to stress is that, yes, we're doing well, and maternal mortality starts from pregnancy, delivery, up to 42 days after delivery. And therefore, what are the things are we putting in place that we are doing to ensure that these are helping us to reduce these indicators? So one of my take-home messages is that, yes, when people are pregnant, they go to the hospital for antenatal care. Third trimester has increased to 63. But let's think about it. What's happening to the 37% who do not go the first 3 months? So then they might miss something out there. Again, when it comes to delivery, we have over 80 being delivered in the health facility. What's happening to the 13%? Or if you add the TBA, what's happening to the 17%? When it comes to postnatal, that is after delivery, we realize that whether your BP was checked, whether 3 indicators that were being there, we are way below. So pushing that to be able to ensure that we bring maternal mortality down. Pregnancy, what happens in there? Because the WHO recommendation of having 8 or more from what was shown, it means that if you are following on the 8 or more, we are barely at 39%. What are we doing to push up? It's encouraging that those who did 4 to 7 are hovering in there. What will we put in place to ensure that those who are doing the 4 to 7 will hope to get to the 8 we are talking about? During delivery too, how we ensure that all these people who went for antenatal care would deliver at a health facility and then be attended by a skilled birth attendant. And again, within the next 42 days, so that we do not record maternal mortality, what are we doing to ensure that all those women receive that health care in there? And so I think that there has been a very fruitful deliberation for all of us. Many more for us to chew on. Thank you, Ghana Health Service. Thank you, Ministry of Health. Thank you for all our partners. Without you, we cannot do this. We are just to put the information out there, and how you respond to it and you take it forward will mean whether Ghana will develop. And so we are very enthused and happy at how far you have taken it and what steps you're putting in place to ensure that come the next DHS, come the next survey, we'll be able to bring some of this to conclusion, or maybe reduce them further, so that we ensure that we are done so much. One activity that I will crave your indulgence to do before we leave is, before the DHS dissemination, we have always been in partnership with them. Dr. Boateng, please, and your team come over so that we hand over the certificates to these media men and women that we have engaged from time to time, and then the training how to report some of our figures. So can we have that session, and after that, maybe we'll close from here. And then roadmap ahead, because we said the next 2 months, we are disseminating module by module to ensure that we get all in place. After this session, we'll meet again, and I believe that that will be to disseminate on HIV/AIDS and health insurance. And so we're tackling step by step so that we engage all stakeholders and all those who use that information to ensure that this information have been drummed down to the level that our policymakers and our planners will use that information. And after the 2 months of this national dissemination, we'll zoom into the various regions and ensure that we do this same detailed dissemination, so that all we want is uptake of the data and information to improve Mother Ghana. Thank you. Please, are the certificates here, or they shared them already? Oh, all right. Thank you so much.
Thank you all so much for being with us from morning till this time. We also want to thank our development partners and our collaborators for ensuring that we are able to come up with these results. After the closing prayer, we'll take photographs. So the presenters and then those in the front will come up here and take pictures. We'll now call on Imam Muhammad Abdullahi to give us the closing prayer for God to guide us for the rest of the day.
We thank the Almighty Allah subhanahu wa ta'ala. As at the time that we are about to start the program, we committed ourselves to Him and thank God that we've had a successful program. We pray that may the blessings and mercy of Allah be upon all of us. We also ask the Almighty Allah to carry us to our various homes safely. And this report that we've been able to bring out today, we pray that all stakeholders should also get access to it, and then make sure that they work on it so that we'll improve Mother Ghana. May God Almighty Allah accept our prayers. أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم الحمد لله رب العالمين الرحمن الرحيم مالك يوم الدين إياك نعبد وإياك نستعين اهدنا الصراط المستقيم صراط الذين أنعمت عليهم غير المغضوب عليهم ولا الضالين آمين.
Amen. Okay, thank you all so much. We now invite Prof. Dr. Engwa, Mr. Boama, our presenters, Dr. Prepara, Mr. JB, Dr. Boateng, Mr. Fofie, Dr. Fofie, please come up stage for pictures. And we have lunch in the foyer, so as you go out, please pick one. Thank you.